So, if you look at the solution here, see there are two solutions, one is protein is 1 molar solution here and protein is 1.8 molar and urea is 0.2. Both protein and urea are exerting osmotic pressure, and if you measure the total osmotic pressure, it is 1 millimeter, 1 molar. That means it is isoosmotic, because total strength is 1 molar. If you look here, protein is 0.8, but protein is 0.8 here also, and urea is 0.2. Protein is not permeable, but urea can pass through. So, a fraction of the osmotic pressure which is exerted by the impermeable solute is called oncotic pressure. Is this part clear? A part of the osmotic pressure exerted by the impermeable solute, in this case it is protein molecule, not urea, and therefore this solution is isoosmotic, but compared to this one, this is hypertonic. This is isotonic, but this is hyperosmotic. So, colloidal osmotic pressure, which you will be reading, that is in the plasma. Many a time you will see that is not written colloidal osmotic pressure, but oncotic pressure. The reason is that it is because of the plasma proteins which are impermeable. So, importance of albumin in plasma oncotic pressure is that the total serum concentration is 6 to 8 grams per deciliter, and albumin constitutes 60% of the total protein. So, it exerts maximum amount of plasma oncotic pressure, not osmotic pressure I am telling you. It is colloidal osmotic pressure. Because of the decreased size, its maximum number of molecules, and it exerts maximum number of osmotic pressure. So, in the plasma, if you see, that is PCB is about 45% and plasma is 55%, and in the plasma many things are dissolved, inorganic, organic molecules, and total proteins are present in the maximum amount, that is in the gram concentration. Do not ever forget that it is present in the highest concentration, in the maximum amount, and there are other things which are present. So, composition of blood is basically 90% water, 10% solid, and today my thrust area is this one, that is protein. That total protein, I can repeat, that is 6 to 8 grams per deciliter, and albumin constitutes 60% of the total protein and is the main determining factor of plasma osmotic pressure, and globulin is 2.5 to 3.5. Remember, there are many things which you have to remember in today's class. You can't imagine how many substances are present in the plasma, but all are present and most of the things are measured. So, today our class is on plasma proteins. I will cover as much as possible today, rest I will cover tomorrow. So, you have measured blood glucose. There is a specific method. You have allowed a chemical reaction to occur and the glucose was identified. Similarly, maybe you have done creatinine also, total protein. That total protein has been allowed to react, but what was the different types of total protein, that you don't know. So, for cholesterol we are having a separate method. So, in the blood, in the plasma, there are several molecules: sugar, blood glucose, urea, cholesterol, creatinine, but for that we do have a specific method. But now plasma proteins are a heterogeneous class of molecules. It is very difficult to actually identify those molecules. So, one method of protein separation is electrophoresis, and this is a laboratory technique which will be dealt with in your practical class in detail. I am telling you briefly, very briefly. It's a technique to separate protein molecules based on their size, shape and electrical charges. Why electrical forces? Because in an electrical field, the movement of particles will be dependent on the charge, on its charge. So ideally, what is done in the normal blood pH, usually pH 7.4, all the proteins are usually negatively charged. In spite of that, there might be some positively charged proteins, so that the entire protein molecules are made negatively charged in a laboratory, allowed to move in an electrical field. The basic purpose, the movement will depend based on the size, shape and molecular weight. Basically, an electrophoretic system will consist of two electrodes of opposite charge, and they are connected to a medium through a buffer system, and electrical current is passed through a gel and a supporting medium. This supporting medium can be paper, that can be a gel, just like jelly-like material which you will see, and there is movement of particle from negative side to positive side. So what is done here, suppose if it is a filter paper electrophoresis or cellulose acetate membrane electrophoresis, which I have done several times, and this is a very common procedure, but the only thing is that this is time consuming. It takes about 6, 8, even overnight, 12 hours time. It's a time consuming procedure. So in the filter paper, the sample is soaked here and it is put in the buffer, and an electrical current is passed. So whatever the substance is present in that solution, they move according to the size. So this is agarose gel. This gel means that is a jelly-like substance. You think of a small, very thin film of jelly on which a small wells, micro wells are formed, in which the samples are dispersed, maybe 1 microliter, maybe 2 microliter. You have dispersed 20 microliter, 10 microliter during the practical class, but here hardly we apply 1 or 2 microliter, and then this electrophoresis is done and the particles move from negative side to positive side, and depending on the molecular weight, they will move differently, and at the end you will get this type of picture. Now whether which one is present you don't know, so therefore you need to stain it, just like colorimeter. You need to stain it. You have to stain it to identify those things. See what you have seen during your colorimetry, this color, this part recording, this recording of that separation is called electrophoresis, just like ECG. That is electrocardiogram. If you take readings of performance of brain, that is electroencephalogram. Similarly, this is electrophoresis. So this is electrophoresis, this picture. That is a consisting of separated molecules. See, you have measured colorimeter. What you have done? You have measured the color, intensity of the color in that instrument. Now here that has been separated. Now again that color, this color needs to be measured, how much it is. So that is done by a similar instrument whose name is densitometer, not colorimeter. So we measure the intensity or density of the color, and that densitometer actually signifies that OD, what you get. If you the concentration or the intensity of the colored solution is high, you will get a higher OD. Similarly, if the concentration is higher here, you will get a higher concentration. As you can see, this is a peak. So from negative to positive, you will get albumin, then alpha 1, alpha 2, beta 1, beta 2, gamma 1, gamma 2. So alpha, albumin, alpha, beta and gamma, that will be the sequence from positive to negative. So major plasma proteins consist of three things. One is alpha albumin, that is the major in the major amount that I have told, and globulins, that alpha, beta and gamma. At least you must be able to tell this major plasma proteins, and that is alpha is divided again in alpha 1 and alpha 2, beta again beta 1, beta 2, and gamma. There are 5 gamma globulins. These are called basically immunoglobulins, which I will cover tomorrow. IgG, IgM, IgA, IgD, IgE. So similar, it looks similar, but the moment I will show you the chart of alpha 1, alpha 2, it will be really baffled that it is very difficult to remember all those things, and there will be sheer confusion whether it is belong to alpha 1, alpha 2 or beta 1 or beta 2. But you have to memorize, because this will be required for MCQ purposes and maybe as a short note also. So all plasma proteins are synthesized by the liver, remember. That you must remember, except gamma globulin. That is synthesized by the plasma cells, which are differentiated forms of B lymphocyte. That I will discuss tomorrow. So again I am repeating that the total protein is 6 to 8%, albumin 3.5 to 5 gram. You must be able to tell this figure. Now globulin is 2.5 to 3.5, and that AG ratio, albumin is always higher than globulin, that is 1.5 to 1.2 is 1. And if that ratio is reversed by any chance, that is 100% pathological. That if the globulin level is higher than the albumin, then that is a pathological condition. That's not normal until proved otherwise. Fibrinogen we do measure for certain conditions, and there are other proteins which are not that important, but these are important for certain conditions. So many methods of protein estimations are there. One method you are using, that is total protein for biorate. And for albumin there is a method called BCG that will specifically bind with the albumin, and the albumin concentration in the blood will be measured. So these main functions of plasma protein you must remember. The major function is maintenance of oncotic pressure. If you know that part clearly, this part, you will be able to treat a patient properly, which I will show you at the end. If you are very much clear about your biochemistry knowledge, you can overpower the clinician also, which I did, and I will show you at the end. That clear concept about plasma protein is required, that it is maintaining the oncotic pressure, I repeat, and there is binding, and it acts as a carrier protein. Albumin is a dunking molecule, it carries a number of things. Bilirubin, it is very specific in the way that bilirubin is transported by albumin, fatty acid, thyroid hormones, steroid hormones, and most of the drugs they are carried by the albumin, and that albumin being present in the very large amount acts as a reservoir, and there is a dynamic equilibrium between the bound form and the free form. From the bound form, slowly the free forms are released and the free form is active, be it hormone, be it drug. So that albumin is very much important because its quantity, its quality, and other metabolic factors also. Globulins, there are specific globulins that I will discuss in a short while, that is TBG, that is thyroxine binding globulin, cortisol binding globulin, sex hormone binding globulin, ceruloplasmin I will discuss in detail, which is a copper binding protein, transferrin, remember it is required for iron uptake and distribution, haptoglobulin, specifically captures free hemoglobin in the circulation. Otherwise, hemoglobin will be appearing in the urine. Hemoglobin might appear when the capacity of the haptoglobin is saturated. It usually holds the free hemoglobin if by chance it is released, and it does happen during disease condition. Hemopexin, that is by heme binding. So there is, you must remember between the two, transferrin is for iron, haptoglobin is for pre-hemoglobin, and hemopexin is for heme. And there is one more protein, that is hepcidin, about which I will tell you. It's a chief regulator of iron homeostasis and produced by the liver exclusively. Fibrinogen, you must have heard, and that forms a readily mobilized building block for fibrin mesowork. Coagulation factors are all latent proteins, just like enzymes, and there is a cascading effect once the coagulation system is activated, and that's why there is if there is any bleeding from any side, that side gets blocked because of the rapid activity of the clotting factors of coagulation factors, and most of the coagulation factors are, all the coagulation factors, almost all are, except a few, are synthesized by the liver. In addition, there is a clot inhibitor, there will be some regulation. See, if there is a intravascular clotting, that will cause thrombosis. Through that thrombus will percolate, move through the small vessels, and it will block the capillaries, and that will cause ischemia, anaxia, which is not desired. So that is regulated by the antithrombin. And antithrombin 3, they confine basically in the area where there is a wound, where there is sealing is required. Immunity is conferred by the gamma globulin, about which I will discuss tomorrow. And complement system, this chart is basically for orientation purposes. Everything you will read in detail later. Buffer, this protein is also having some role in buffering, because there will be acidosis, there will be alkalosis, but neutral pH has to be maintained at any cost, and plasma proteins being negatively charged, they usually neutralize any acid form. So they are having a buffering role also, and some of the circulatory proteins remain in the inactive form, and one of the classical example is angiotensin, and that is a regulator of blood pressure. It is from angiotensin, it is converted to angiotensin 1 and angiotensin 2. Now, as I told you that if we measure that densitometric scanning, this albumin being in the largest amount, it will produce a larger maximum amount of peak. If that peak is less, that means albumin concentration is less. Although for albumin, we do not do electrophoresis. Electrophoresis is basically targeted for finding these abnormalities, this alpha 1, alpha 2, beta or gamma. It is not for albumin, because we are having a method, chemical method for estimation of albumin in the laboratory. So by chance, if there is in the electrophoresis report or electrophotogram, if you find that albumin peak is low, that also indicates abnormality. So it is the largest peak. Globulins are smaller fraction than albumin, and the representation of the electrophoresis primarily depends on the serum protein electrophoresis, which involved alpha 1, alpha 2, beta and gamma, not albumin. This I must emphasize. So elevation of interpretation of elevation, decrease or visual change in that part occurs in different disease conditions, and you will be able to identify which part, where there is abnormality, whether it is present in the high amount or it is in the low amount. So that will arouse suspicion, and accordingly will advise for further investigation, and at times it will be diagnostic itself. And once you have made a diagnosis, it will be required for monitoring also, because whether the peak is that same or it is increasing or it is decreasing. So now coming to the picture that I am telling you, how many belong to alpha 1 globulin, that you must remember. This chart you have to remember, there is no way out. Because there will be questions, there will be MCQ questions that which it belongs to which part of the globulin, alpha 1, alpha 2, beta 1, gamma. Suppose this ceruloplasmin belongs to alpha 2 globulin, alpha 1 globulin, not alpha 1 globulin. So this at least you have to remember. Similarly, for beta globulin, there is only a few major important proteins which are. You will read it, you will get it in the book. Now you just you just try to note it down so that you remember what I want. Everything is written in the book. Only thing is that you have to memorize. There is no way out for these cases. I have selected only a few which are relevant clinically. There are much more numbers which are present in the book, but all will not be required. At least you must be able to tell this part. These are the only few that even I have marked it. Even if you cannot say this thing, it will hardly matter. But try to remember the alpha 1 antitrypsin, alpha 1 anti-chymotrypsin. Similarly, here alpha 2 globulin. At least you must be able to tell these four. Ceruloplasmin I will tell in detail, and one is important is angiogen tensionogen, that is of clinical relevance. So thyroxine binding globulin, cortisol binding globulin, these are I have highlighted so that at least you must be able to give some examples of alpha 2 globulin, give some examples of alpha 1 globulin. At least if you tell alpha 1 antitrypsin, alpha 1 anti-chymotrypsin, at least we will be happy to see. Happy to note that you know that alpha 1 antitrypsin name is there. And I will discuss only those parts which are relevant. So this again you see, I have listed only 2 out of this. These 4 I am not discussing because these are not that much clinically relevant. So about these 2 things you must remember because this is related to common disease. And this is asked as an MCQ. Suppose pulmonary emphysema is caused by this alpha 1 antitrypsin deficiency. It's a common question. So what does alpha 1 antitrypsin does? See, trypsin is a proteolytic enzyme. So antitrypsin means it is an antiproteolytic. So it is a protease inhibitor. So it inhibits various proteases. It protects the tissue enzymes from inflammatory cells, especially neutrophil elastase. Now, the importance is that when there is deficient, this enzyme is deficient, that neutrophil elastase destroys the pulmonary structure. That see, lung is expanding, lung is collapsing with inspiration and expiration. The presence of elastic tissue in the lungs, that elastic tissue elastin will be destroyed by alpha 1 antitrypsin. This elastin will be destroyed by the neutrophil elastase, and lung will no longer be having that elastic power, and it will give rise to a condition that is called pulmonary emphysema. I will show you an X-ray picture of what a normal lung looks like and what an emphysema lung looks like, and that will be basically due to alpha 1 antitrypsin deficiency. Similarly, alpha 1 anti-chymotrypsin is an acute fast protein. When there is an inflammation, when there is activation, so there will be an acute fast protein, and this deficiency is associated with Parkinson's disease, which you will see later, and Alzheimer's disease. Alpha 2 globulin. This is thyroxine binding globulin, it binds T3 and T4. Cortisol binding globulin, it is also called transcodin, and it binds to several hormones, particularly cortisol, with 90% capacity. So vitamin D binding globulin, haptoglobulin, I have told you already, there is a high affinity for hemoglobin, free hemoglobin, ceruloplasmin. Again, copper carrying protein and deficiency causes Wilson's disease. Again, a MCQ question. Wilson's disease is caused by deficiency of ceruloplasmin. Alpha 2 microglobulin, alpha 2 macroglobulin. This is very important because in the nephrotic syndrome, are the cases which we will see clinically that albumin concentration will be decreased, and to maintain oncotic pressure somehow this alpha 2 macroglobulin will be increased in a significant amount and its concentration will be high, and in the electrophoresis you will see a peak at the alpha 2 position. So angiotensinogen, again during blood pressure regulation you will find that angiotensinogen is a renin substrate. Angiotensinogen is flipped by angiotensin converting enzyme to angiotensin, from angiotensin 1 to angiotensin 2, and it is a potent vasoconstrictor. So those patients who are suffering from hypertension, these AC inhibitors, that means drugs are used so that there will be inhibition of the angiotensin converting enzyme, so that angiotensin 1 cannot be converted into angiotensin 2. Consequently, there will be less rise in the blood sugar. That's a clinical implication. So carrier proteins, it's a very brief introduction. One thing I want to highlight only albumin, that I told you it combines with its transported number of molecules. And the most important thing is that most of the drugs are transported through albumin, and there will be competition between the drug and the substances, endogenous substances, for the limited number of binding sites on the albumin, and it will displace. So there will be some amount of problem in interpretation in the disease conditions. If a drug is administered, there will be false elevation of some free hormones or free other substances which are carried by the albumin. So this transport protein you just read, I am not covering. Ceruloplasmin, I repeat, this is one important plasma protein, and it's a major copper carrying protein, and it is related with iron metabolism also. So 95% of copper is carried by the ceruloplasmin, and it's a copper dependent oxidase activity. You see that iron is Fe2 plus is converted into Fe3 by ceruloplasmin, and it is in this form iron is transported. So ceruloplasmin is in that related, it is copper dependent oxidase, and that helps not only for copper metabolism but also iron metabolism. So it is having, apart from copper dependent oxidase, ferrooxidase activity, oxidoreductase activities, and a binding, that is a chaperone or metal ion. Chaperone is a small protein which helps in the protein folding, which you will see during protein synthesis. Hepcidin, remember one thing, it's somehow called pre-pro-hormone, that is synthesized as the pre-hormone, 84 amino acid. Normally, erythropoietin, there are many hormones which are peptide in nature, but they are not classified as hormone. There is a separate thing, but the terminology of that particular definition of hormone is produced in one organ in the endocrine and exerts performing at other sites will no longer be true. The concept is changing. So that's why hepcidin is called a pre-pro hormone also. And finally, from pre-pro to pro, just like insulin, a cleavage, and finally this 25 peptide hepcidin is formed, and it's really a regulator of iron metabolism. What it does, you see that iron in the intestinal lumen that is transported by that is present in the diet is reduced to Fe2 by deuteral cytochrome B, and there is a divalent metal ion transporter which transports iron here, and then this iron is released into the circulation. Similarly, when the RBC is senescent, means old, this is engulfed by the reticuloendothelial cells, and it is digested. That heme is digested. From that heme, that biliverdin is produced from biliverdin to bilirubin. Now this iron is produced here this iron is again released in the circulation. Now there is a clear iron conserving mechanism. So when the blood level of iron is very high, iron level is increases, hepcidin also is increased. What hepcidin does? Hepcidin binds with the iron and that is engulfed, that is internalized. So degradation, hepcidin binding and triggering of internalization and degradation of ferroportin, which is expressed only in the enterocyte and in the reticulocyte. See, there is two ways of regulating iron. One is at reticulocyte and another is at intestine. From intestine, we are absorbing exogenous from the diet, and what is produced in the body, that is formed by the reticuloendothelial cells, because senescent RBCs are engulfed by the reticuloendothelial cells. So, in order to control the iron level, iron is a very valuable microelement because it is required for heme synthesis. So, body doesn't want iron to be lost, it has to be protected somehow, and hepcidin does this function by through its regulation and through its production by the liver. So, hepcidin is the chief regulator of iron homeostasis. Remember, when the plasma iron level is high, hepcidin level also becomes high, and it reduces both iron reabsorption and recycling. But remember one thing, everything has got a capacity. When the capacity is exceeded, obviously this will not function and iron will be deposited in the tissue, and that will cause hemosiderosis or hemochromatosis. So, iron, it's hepcidin, basically iron transmembrane transporter inhibitor activity, signal receptor. See, hepatocyte monitor iron level in two major mechanisms. One is through transferrin receptor 1, which is present in the most cells, and most cells require iron for binding activities, as we have known that iron dependent enzymes are there. So, they are having a high affinity. In contrast, on the hepatocyte and on the cryptic cells of the small intestine, there is transferrin, this TF will be small one, that is transferrin receptor 2, that acts as a sensor. This you must remember. It is bound to a third protein, membrane protein, that is HFE. And this is the main regulator of iron. You must remember this thing. And hepcidin expression is influenced by the iron level in the blood, erythropoiesis, inflammation and hypoxia. See, pathogens, when we enter into the system, they want iron. They derive iron from our body stores. So, iron level is low. So, that initially hepcidin was identified, it's a really recent advanced research. It was identified in the year 2002. It's a novel research molecule for antimicrobial properties. So, hepcidin name is derived from, hep is from liver and cidin means it is a killing effect. So, what does this do? Basically, it captures iron so that the pathogens will not get iron for its proliferation or for its nutrition. So, this is an acute phase reactant protein due to interleukin 6. So, albumin, it's a major abundant plasma protein, that is 3.5 to 5. I have told you at least 6 times. It is synthesized by the liver, 12 gram, 25% of the total protein synthesis, synthesized at pre-proalbumin, just like insulin again. So, then N-terminal was removed and proalbumin claimed into the Golgi apparatus to albumin. It's highly water soluble and monomeric. It is having a molecular weight of 67,000 and it doesn't pass normally through the glomerulus. It facilitates transits of fatty acids, steroid hormones and other ligands between tissues. These functions of albumin you must remember. And one important thing is that it is a serum half-life of 21 days, and that is the basis of many drugs and drug designing also. They encase on this. However, this is a protein in nature, so there will be mutation in the albumin gene, and abnormal albumin with abnormal binding property will also be there. So that will cause dysalbuminemia, and it will cause false interpretation. So this is in albumin. The way I am telling, this is not that simple. This is a very schematic diagram. So there are 3 binding sites. One is 1, 2, and 3. This is again subdivided into 2A, 2B, 3A, 3B, and so there are total 6 binding sites. So major binding domains are 1, 2, and 3, and for all proteins there is a binding domain for binding to that particular biomolecule or ion, whatever is required for its transport. So functions of albumin, you must remember that, you have to just note down. Because this I want that you first tell that this maintains colloidal osmotic pressure or oncotic pressure. Transport of hydrophobic substances which are not soluble in the water, multiple ligand binding sites, thyroid hormones, although for thyroid hormones we are having a thyroxine binding globulin, but a part of albumin T3 and T4 is transported by the albumin, and T4 for T4 binding, that is TBG and TBPA is there. Other fat soluble hormones are transported. Unconjugated bilirubin is transported, as I have told you during bilirubin class. Many drugs I told repeatedly, and there will be competition for the binding site between the drug and the endogenous substances. It acts as a negative acute phase protein and down-regulated during inflammatory states. Its buffering action is there. It prevents photodegradation of folic acid. And another important part is Clostridium difficile toxins, which you will read in the microbiology class. So starting equation, I will rapidly almost coming to the end, but remember this part is very important. I will show you a case right now, clinical case. Starting equation, that means there is a fluid movement between the tissues is determined by the hydrostatic pressure and the colloidal osmotic pressure between the plasma inside the vessel and the extracellular space. Now, if you recall the capillary structure, there is a basement membrane concentrate here. This is most important, and that will be asked during examination, and it will be clinically relevant. You see there is a basement membrane, this is a capillary, and blood is moving through this thing, and larger molecules are not passing. It's a schematic representation. There are 2 pores are there. Through the pores usually water and the water soluble substances pass through. See this at the capillary end. If you look at the blood pressure at the arteriolar end of the capillary is 35 millimeter. Colloidal osmotic pressure, it is present, it cannot come out from the capillary, it remains 25 at the capillary, this arteriolar end, and 25 also at the venular end. So that osmotic pressure is fixed, that is 25. Blood pressure is 35 here, blood pressure is 25 here. So there is a difference of osmotic pressure, that here it is high, 35, and 25, the difference is 10. So fluid comes out from the blood vessel into the intravascular space, and at the venular end there is a negative pressure, and which helps in sucking the amount of fluid which has come out from the circulation, and it is taken back into the system because albumin is present. Now, by chance, if the albumin level is low, then this colloidal osmotic pressure, that 25 will drop down. So if that instead of 25, it is, suppose it is 15, now the gap is here is 20, gap is here at 20, so more amount of blood fluid will come out. Now again this will be here 25, so the fluid will not be able to take up by the venular end. So there will be accumulation of extracellular fluid in the tissue space, and that is the basis of formation of edema. So maintenance of albumin in the blood, the albumin synthesis is basically what, there is a balance in the normal situation in our body. None of us is having edema because we are having this part, this 10 millimeter, both here, 10 millimeter filtration pressure here and 10 millimeter sucking pressure here. So there is no accumulation of fluid here. But the moment the plasma, there is a gap, there is a drop in the osmotic pressure, which is primarily due to albumin. There will be accumulation of fluid in the extracellular space. So low albumin due to any condition will cause edema. So pedal edema, if you see many times you will see, this is a picture. You will see the located, our feet, none of you are having the edema. It can be localized in the abdomen. It can be in the face also. These all I have taken from the internet picture. So this is a manifestation of edema. When it is present in the face, it indicates usually nephrotic syndrome. When it is in the leg, it is usually congestive cardiac failure, or this part is basically due to hypoproteinemia, hyperalbuminemia. This is a typical picture which I have taken from our hospital patient. Albumin level was almost 2. I still remember 1.8, and I rushed to the ward and took a photograph of the lady, and you see the degree of swelling. So this is called anasarca, that is a generalized body swelling. This is only one of the causes of swelling of leg, face and body is hypoalbuminemia. One of the causes. So when you find a generalized edema, think of hypoalbuminemia first. The two most common causes of hypoalbuminemia, one is nephrotic syndrome. That means there is a leaking of albumin, and that is causing a drop. And this nephrotic syndrome is defined. Note down this thing. This will be required. This is from Harrison's book. You will read the latest Harrison book, and you will read in the medicine book. Edema and hypoalbuminemia less than 3.5 and proteinuria more than 3.5 gram per day in an adult. That's the standard definition of nephrotic syndrome. Otherwise, there will be swelling, but it will not be nephrotic syndrome. But these three criteria has to be satisfied. Along with that, there will be high LDL and high low LDL and lipidemia. But these three must be present. And chronic liver diseases. Why? Because liver is producing albumin. So a liver is having a large reservoir of capacity. So liver disease, usually advanced chronic liver disease, there will be hypoalbuminemia. You just think of these two conditions first, and in the examination also you will tell this thing. Nephrotic syndrome and advanced chronic liver diseases, cirrhosis of the liver is the most common cause found in the day-to-day living. So how you will treat this case? So nephrotic syndrome, there is leakage of urine. So you have to prevent the leak. So the disease which is causing the nephrotic syndrome, that disease has to be treated. And usually steroids are used to reduce inflammation. In contrast, if there is a chronic liver disease, that means the liver is unable to produce, so liver is unable to produce that adequate amount of albumin because its cells are defective. That is the reason why, and that too has to be chronic, because 1/6 of the liver, if it is present, then the body functions will function. So 5/6 liver has to be damaged at least, and it will be remaining touching the basically 1/6, then only you will get this type of picture. So one of the things is that treatment, how you can treat this patient. One is leaking for nephrotic syndrome, but for liver, if you give a high amount of protein, so that you are giving a natural source, some amino acid source to the liver, so the liver can synthesize. But the problem is that if the liver cell is defective, there are many commercial preparations which are available, but poor persons, you advise for egg albumin. This is the most reference protein which the patient can take. These are very costly, that will cost 600, 700 rupees. But at 600, 700 rupees, the patient can get at least 100 eggs. So that will be a better choice for a poor person rather than going for this thing. Only advantage is that, it's a pure form. I'm stopping it here. Tomorrow I'll show you. So one way is of giving, depending on the capacity of the person, to advise either egg albumin or protein, that milk, or if it is required, there is IV preparation also, there is intravenous albumin, which are used therapeutically. I'll show a case of this thing tomorrow. Okay? And rest which I will not be able to cover, I will cover in the small group discussion. So the objective of today's class was to see that if there is hyperalbuminemia, you treat, either stop the leakage or increase the synthesis. And there are two ways, and this will be miserably failed during chronic liver disease. Because liver is not able to produce. So only option is to give IV, to give a rapid injection. So with this I conclude, and
this is the foregut, and you can see this blue respiratory diverticulum. Now this is the heart, developing heart, vitelline duct, allantois, cloacal membrane, and the future stomach is here, the liver ward is here, the duodenum, midgut, and the hindgut. And the embryo of approximately 25 days gestation, showing the relation of the respiratory diverticulum to the heart, stomach, and liver. Now, the sagittal section through the cephalic end of the 5th week embryo shows the openings of the pharyngeal pouches and the laryngotracheal orifice. The attachment of the buccopharyngeal membrane, the respiratory diverticulum here, openings of the pharyngeal pouches, and this is the laryngotracheal orifice. I think one of the best books, and easily you can grasp this embryology subject, is Langman's embryology. It's very illustrative. In modern publication, they are giving a CD also. Now you can look into that. But in the embryological component of your questions is not very much vast, like one full 25 marks question or something like that. Now, but you have to know the main tissue components, that it comes from endoderm or mesoderm or ectoderm. Now, initially, the lung bud is an open communication with the foregut when the diverticulum expands caudally. However, two longitudinal ridges, the tracheoesophageal ridges, separated from the foregut. Subsequently, when these ridges fuse to form tracheoesophageal septum, the foregut is divided into a dorsal portion and in the esophagus and ventral portion, the trachea and lung buds. The respiratory primordium maintains the communication with the pharynx through the laryngeal orifice. That's why you can see the larynx, pharynx, and esophagus. When you swallow some food, in case there is it goes, enters the larynx, then you have a respiratory distress. Okay. Now, beautiful illustrations, easy to grasp, is the A, B, C, D. Now, A, B and C are successive stages in the development of the respiratory diverticulum, showing the tracheoesophageal ridges and formation of septum, splitting the foregut into esophagus and trachea with lung buds. You can see this is the ridges, foregut, esophagus. This is the trachea and lung bud, the respiratory diverticulum. And the laryngeal swellings here, tuberculum impar, lateral inguinal swelling, now foramen cecum, and epiglottal swelling, laryngeal orifice, this is a slit there, and laryngeal swellings are here. Now, clinical aspects. Now, abnormalities in partitioning of the esophagus and trachea by the tracheoesophageal septum results in esophageal atresia with or without tracheoesophageal fistulas, TEFS. Now, these defects occur in approximately in 1 by 3,000 births, and 90% result in the upper portion of the esophagus ending in the blind pouch and the lower segment forming a fistula with the trachea. Isolated esophageal atresia, H type TEF, without esophageal atresia, each account for 4% of these defects. Other variations each account for approximately 1% of these defects. These abnormalities are associated with birth defects, including cardiac abnormalities, which occurred in 33% of these cases. Now, actually, this type of defects in congenital malformations, the cause is not known exactly, and there will be either one single defect or maybe multiple defects. Now, if a child is born and having some respiratory distress, also in the NCU, if you observe that it is having even swelling or some distress, then you have to think in this line. Okay? Now, this is the trachea, bifurcation, bronchi, and see the proximal blind end of the esophagus. Now, tracheoesophageal fistula, distal part of the esophagus. Now, the different varieties, various types of esophageal atresia and or tracheoesophageal fistula. A, the most frequent abnormality, 90% case occurs with the upper esophagus ending in a blind pouch. Here, this is a blind pouch, and the lower segment forming a fistula with the trachea. Isolated esophageal atresia, in this isolated. It is not communicating with the trachea. And the communication of esophagus with the trachea. See the different varieties. This is a blind pouch ending. This does not continue with this esophagus, distal end of the esophagus. Now, but it is communicating with the bifurcation of the trachea. Here, two blind ending. A communication of the esophagus. See, one again directly communicates, and here these are the C type, tracheoesophageal of 4% of cases, D and E, other variations are 19%. In this regard, TEFs are component of the vectoral association, vertebral abnormality, anal atresia, cardiac defect, tracheoesophageal fistula, esophageal atresia, renal abnormalities and limb defects. A collection of defects of unknown causation, but occurs more frequently than predicted by chance alone. Now, if you have some a baby with a limb deformity or some cardiac deformity, then you think in this term. A complication of TEFS is polyhydramnios. Since in some types of TEF, amniotic fluid does not pass through to the stomach and intestine, also gastric contents or amniotic fluid may enter the trachea through the fistula, causing pneumonitis and pneumonia. Now, polyhydramnios, you will be diagnosed in the ultrasound. Okay, that means at least 3 USG you must conduct, and 1 anomaly scan must be conducted in 18 to 22 weeks, and 1 NT scan, neurative effect with the biochemistry also in the on 14th week of pregnancy. Now, larynx. The internal lining of the larynx originates from the endoderm, as I told you earlier, but the cartilages and muscles originate from the mesenchyme of the 4th and 6th pharyngeal arches. 4th and 6th pharyngeal arches. As a result of rapid proliferation of this mesenchyme, the laryngeal orifice changes in appearance from a sagittal slit to a T-shaped opening. Now, a sagittal slit, it now shaping and reshaping. Some tissues are dissolution is taking place, and some tissues are coming into the formation of the structures. Now, subsequently, when mesenchyme of the 2 arches transforms into thyroid, cricoid and arytenoid cartilages, the characteristic adult shape of the larynx orifice can be recognized. At about the same time, the cartilages are formed. The laryngeal epithelium also proliferates rapidly, resulting in a temporary occlusion of the lumen. See, this is the lingual swelling, this is the foramen cecum, the epiglottal swelling, and this is the T-shaped, this is the arytenoid swellings. Now, in B, this is in 6 weeks, but by 12 weeks, if you see the epiglottis, the laryngeal orifice, and arytenoid swelling here. Now, subsequently, vacuolization and recanalization produce a pair of lateral recesses, the laryngeal ventricles. These recesses are bound by folds of tissue that differentiate into the false and true vocal cords. Now, the vocal cords is formed by vacuolization and recanalization produce a pair of lateral recesses, the laryngeal ventricles. These recesses are bounded by folds of tissue that differentiate into the false and true vocal cords. Now, since musculature of the larynx is derived from the mesenchyme of the 4th and 6th pharyngeal arches, the musculature of the larynx is derived from the mesenchyme of the 4th and 6th pharyngeal arches. All laryngeal muscles are innervated by branches of the 10th cranial nerve, the vagus nerve. The superior laryngeal nerve innervates derivatives of the 4th pharyngeal arch, and the recurrent laryngeal nerve innervates derivatives of the 6th pharyngeal arch. Now, trachea, bronchi and lungs. During the separation from the foregut, the lung bud forms the trachea and 2 lateral outpocketing the bronchial buds. At the beginning of the 5th week, each of these buds enlarge to form the right and the left main bronchi. Here the lung bud, right and left bronchus, and the right then forms the 3 secondary bronchi, and the left 2 thus foreshadowing the 3 lobes on the right side and 2 on the left side. See it's the developmental of the lung it is having the right lobe as 3 and left is having 2. This is by 6 weeks and 8 weeks. Now, with subsequent growth in caudal and lateral direction, the lung buds expand into the body cavity. The spaces for the lungs, thus pericardio-peritoneal canals, are narrow. They lie on each side of the foregut and are gradually filled by the expanding lung buds. See, this is the parietal pleura, this is the visceral pleura, these are the lung buds, and pericardio-peritoneal canal, this portion, trachea, pharynx, and the visceral peritoneum. This. Similarly, lung bud is there, pleuropericardial fold, this is the common cardinal vein, phrenic nerve, and the heart is here. Ultimately, the pleuroperitoneal and pericardial fold separate the pericardio-peritoneal canal from the peritoneal and pericardial cavities respectively, and the remaining spaces form the primitive pleural cavities. The mesoderm, which covers the outside of the lung, develops from the visceral pleura. The somatic mesoderm layer covering the body wall from inside becomes the parietal pleura. The space between the parietal and the visceral pleura is the pleural cavity. Now, this is the pleural cavity. You can see lining the lung buds. And slowly, as the component of the lungs develop, they are the part you are seeing in the full-grown adult. You see the pleura is more or less very thin space and adherent. Now, during further development, secondary bronchi divide into dichotomous fashion, forming 10 tertiary segmental bronchi in the right lung and 8 in the left, creating the bronchopulmonary segment of the adult lung. Now, if you have a full question or 10 marks question of bronchopulmonary segments, then definitely this component of the embryology part you must mention. Just 2 lines, 2 lines. If it is a 15 marks question, then you do mention the embryological component. Now, by the end of the 6 months, approximately 7 generations of subdivisions have formed before the bronchial tree reaches final shape. However, an additional 6 divisions form during postnatal life. Now, the postnatal life, this developmental part, it extends in the postnatal life. 6 divisions formed during the postnatal life. Now, branching is regulated by epithelial mesenchymal interaction between the endoderm of the lung buds and flanking mesoderm that surround them. Signals from branching which emit from the mesoderm involve members of the fibroblast growth factor family. While all of these new subdivisions are occurring and the bronchial tree is developing, the lungs assume a more caudal position so that by the time of birth, the bifurcation of the trachea is opposite the thoracic vertebra. It is in the mid-level of the foregut. Then slowly it develops and it takes position in the thoracic cavity. The caudal part. Now up to the 7th prenatal month, the bronchioles divide continuously into more and smaller canals, canalicular phase, and the vascular supply increases steadily. Respiration becomes possible when some of the cells of the cuboidal respiratory bronchioles change into thin flat cells. These cells are intimately associated with numerous blood and lymph capillaries surrounding the spaces are now known as terminal sacs or primitive alveoli. See the blood capillaries here, the respiratory bronchioles, the cuboidal epithelium, this blue, and terminal bronchiole. And the cuboidal epithelium, this is thin squamous epithelium, terminal sacs, and flat endothelium of blood capillaries. And during the 7th month, sufficient numbers of capillaries are present to guarantee adequate gas exchange and the premature infant is able to survive. Now, in 7 months, or if there is a twin, naturally 7 to 8 months, premature delivery. Then you have to, now modern NCU are very equipped, you can, it will survive. Or one of the babies may survive. Now, during the, because see why it is the thing that after in a health center, subdivisional hospital, there might be a small unit, but if you deliver and you see a twin of 7 months, don't say, na, eta bachbe na, eta mure jabe, esab bolbe na. Then thale pandemonium hobe. So you tell that a baby guloke bachano sombhob, apnake medical college niye jete hobe. Eta ekta. I happened to deliver this type of twin at 8 months, 2 girls. But in those days, there was nothing to even measure the parameter. The pulse oximeter chilo na, ba kono rokom je monitors gulo esche segulo chilo na. But they are dadi. When I came out from the delivery room, I put them in a bed wrapped up in cotton and also this thing. And so they were Muslims. The dadi was happy. And she said, I'll take care of these 2 babies. So, etake sei bhabe uni feeding bottle tapore breast milk kore they were saved because other anomalies were not there. Etokon respiratory system e dhoro kono esophageal fistula or something, it was not there. তাহলে তাদের ডিস্ট্রেস হতো, তাদের যখন মিল্ক খাওয়ানো হচ্ছে, জল খাওয়ানো হচ্ছে, তখন কিন্তু ডিস্ট্রেস হতো। Ultimately, they are grown up, they are having families. One of the sisters is in Rampurat, married, happily married with children also. So, কে বাঁচবে, কে মরবে, জন্ম মৃত্যু বিবাহ. Your date of wedding, your date of birth, and when you will die, it is in the destiny. But destiny opor chhede dile hobe na. Why I want to stress is that in these conditions, never give up. You have seen cowboy films. You in your YouTube, you see some cowboy films. All are surrounded the hero with a hat and it makes American films, Hollywood films. So, bunduk niye hato sajiye ache. Erom kore hat tule dilo. Hat tule dile mane daitto eri jao na, but you guide. Jetake ekhane niye jan. Jela সদরে নিয়ে যান, তাহলে বাঁচবে বাচ্চাটা। এবার দেখা গেল যে একটা বাচ্চার অনেকগুলো কমপ্লিকেশন আছে, তাহলে সেটা এখন মডার্ন পেডিয়াট্রিক সার্জনস তারা সেটাকে সেটেল করবে। 1 day old, 1 month old children are being operated by the pediatric surgeons. So don't give up hope for all these conditions. Excuse me. Now, see the squamous epithelium, the blood capillaries and the lymph capillaries in yellow and mature alveoli. Now, lung tissue in a newborn, note the thin squamous epithelium cells, cluster known as alveolar epithelial cells, and the surrounding capillaries protruding into the mature epithelium. During the last 2 months of the prenatal life and for several years thereafter, the number of terminal sacs increased steadily. In addition, cells lining the sacs known as type 1 alveolar epithelial cells become thinner so that surrounding capillaries protrude into the alveolar sacs. This intimate contact between epithelial and endothelial cells makes up the blood-air barrier. In addition to endothelial cells and flat alveolar epithelial cells, another cell type develops at the end of the 6th month. These cells, type 2 alveolar epithelial cells, produce surfactant, a phospholipid-rich fluid capable of lowering surface tension at the air alveolar space. Now, there might be some abnormalities in these cells. So, the intimate contact between epithelial and endothelial cells makes a blood-air barrier. So, it might be a small 2 marks question, what is blood-air barrier? Don't panic. Now, before birth, the lungs are full of fluid that contains high concentration. Some mucus from the bronchial gland and surfactant from the alveolar epithelial cells. Type 2. The amount of surfactant in the fluid increases, particularly during the last 2 weeks before birth. Fetal breathing movements begin before birth and cause aspiration of amniotic fluid. These movements are important for stimulating lung development and conditioning of the respiratory muscle. When respiration begins at birth, most of the lung fluid is rapidly reabsorbed by the blood and lymph capillaries, and a small amount is probably expelled via the trachea and bronchi during delivery. Surfactant remains deposited at a thin phospholipid coat on the alveolar cell membrane. With air entering alveoli during the first breath, the surfactant coat prevents development of an air-water-blood interface with high surface tension. Without the fatty surfactant layer, the alveoli would collapse during expiration. Now, it is estimated that only 1/6 of the adult number of alveoli are present at birth. The remaining alveoli formed during the first 10 years of postnatal life through the continuous formation of new primitive alveoli. This is important. Any child is brought to you with a bit of respiratory problem, then you have to tell the mother that you make exercises, tel makhao, bhalo kore iye koro, or mother with the pat koro. So she cries and so the lung blows. Okay. The home remedies. Now, clinical aspect. Surfactant is particularly important for survival of the premature infant. When surfactant is insufficient, the air-water blood surface membrane tension becomes high, bringing great risk that alveoli will collapse during expiration. As a result, respiratory distress syndrome (RDS) develops. This is the common cause of death in the premature infant. Now, the ধরো 8 মাসের একটা বাচ্চা হলো, পূর্ণাঙ্গ ম্যাচিওর নয়, 9 মাসে। So, এবার সেটা ডেথ হয়ে গেল। এই আমার বাচ্চা মেরে দিল, আমার এই করে দিল, একটা প্যান্ডেমোনিয়াম throughout the hospital. So, এবার with these things, even you have to understand that this is the problem. So, but you have to give a try to save the child. By the time you counsel, যেটা আমার আগে যখন আমি নর্মাল বেশিরভাগই নর্মাল হতো, এখনো নর্মাল হবে, পৃথিবীতে জগতে যারাই এসছে তাদের নর্মালি হয়, কিছু কিছু চান্সেস থাকে, কিন্তু এখন modern times you are not taking any risk. So we are doing some planned scissors. That too you have to have a calculation. যে প্রিম্যাচিওর বেশি দিন আগে বার করে না দেওয়া, তাহলে দ্যার বি সাম কমপ্লিকেশন অ্যান্ড প্রবলেম। হ্যাঁ, আমার যেমন জিজ্ঞেস করছে যে আমার বাচ্চা তো চোখ ফুটবে তো, আর চোখ ফোটার সঙ্গে 10 বছর ধরো আজকে 10th, হ্যাঁ আজকে ধরো 7th আগে 10 দিন আগে তুই বাচ্চাটা বার করছিস, যার ডেভেলপমেন্ট হবার তো হয়ে গেছে, এক্সেপ্ট ইন দিস few things are always in the bhanga gora khela. That is developing, that is even maturing. So, but if there is some defect in the surfactant, respiratory distress syndrome, that might be a small 2 marks note question. Now, absolutely known as hyaline membrane disease accounts for up to 20% of deaths among newborn. এই ফিগারটা কিন্তু কম নয়, 20%. যে ডেথগুলো হয়, actually previously in the delivery of the child, we used to allow the mother of the girl or some grandmother or some daima. In the village there was the practice of daima. They used to deliver. And they used to even do PV. যেটা আটকে গেছে না কি করছে, কিছুটা ভালো ডায়াগনোসিস করতো তারা, তাদের স্কিল ডেভেলপ ছিল তাদের। তো একটা দাইমা, মানে একটা গ্রামে তো একটা দাইমা অ্যাকম্পানি করতোই তখন দাইমাকে রাখতাম, বাড়ির কেউ থাকতো, ঠিক আছে, তখন তো ফিটাল মনিটর হয়নি, তখন স্টেতো দিয়ে তারপরে যে fetal movements plus তোমার breathing, and this thing could be gauged. Now, recent development in artificial surfactant and treatment of premature babies with glucocorticoid and to stimulate surfactant production have reduced the mortality associated with RDS and allowed survival of some babies as young as 5.5 months of gestation. Now, this is an interesting fact. So, you will have to explain to the pediatrician you have to refer to. তুমি তো একটা মেডিকেল MBBS নিয়ে মেডিকেল অফিসার হিসেবে জয়েন করবে, তখন এগুলো মনে রাখতে হবে। Although many abnormalities of the lung and bronchial tree have been described, blind ending, trachea with absence of lung, the agenesis of the lung, most of these gross abnormalities are rare, very rare. Abnormal divisions of the bronchial tree are more common. Some result in supernumerary lobules. These variations of bronchial tree have little functional significance, but they may cause unexpected difficulties during bronchoscopies. Now, একটু bronchoscope মানে ধরো আমাদের এখনো সেই লেভেলে খুব কম সেন্টার আছে, আমার ঠিক জানা নেই এই স্কিলগুলো তারা ইয়ে করছে। ও একটা বাচ্চা গেল এরকম একটা মনোভাব থাকে আর কি, কিন্তু ইট ক্যান বি ডান। ইভেন ফিটাল সার্জারিজ আর বিং পারফর্ম, মানে গ্র্যাভিড ইউটারাসের মধ্যে স্কোপস ঢুকিয়ে সেসব টুকটাক সার্জারি করছে। তোমরা গুগলে সার্চ করো ফিটাল সার্জারি, তাহলে পড়ে নিও, সেটা জাস্ট একটা ইয়োর ইন্টারেস্ট, ইয়োর ওন ক্রেভিং ফর নলেজ, you just look into it. Now, more interesting are ectopic lung lobes rising from the trachea or esophagus. It is believed that these lobes are formed from additional respiratory buds of the foregut that develops independently of the main respiratory system. Most important clinically are congenital cysts of the lung, which are formed by dilatation of the terminal or larger bronchi. Okay, these cysts may be small and multiple, giving the lung a honeycomb appearance on radiograph, or they may be restricted to one or more larger ones. Cystic structures of the lung usually drain poorly and frequently cause chronic infection. Now, actually what happened, একটা ছবি করে নাও, যেমন পেটের ছবি করা হয়, তেমনি একটা old modular radiograph. And main thing, the technicians, we are not even equipped. মানে কিরকম ইকুইপ করো, তোমার ইকুইপমেন্ট এসে যাচ্ছে, কিন্তু স্কিলড পার্সনস আর নট দেয়ার। ধরো এমআরআই, সিটি, এগুলো সব টেকনোলজিস্টরা করছে। তো তাদের এক্সপিরিয়েন্স, তাদের পড়াশোনা, তাদের জায়গাটা তাদেরকে সেট করতে হবে। কিন্তু এবার তোমার বিং আ প্র্যাকটিশনার, তুমি যদি একটা ভালো সেন্টারে পাঠিয়ে, তুমি যদি তোমার সন্দেহ হয়, if you feel you have doubt, then get it done from a good center. And personally, if you have some contact number, you personally talk to that person. এটা এরকম হানিকম লিখেছেন, হানিকম দেখছি, তা আপনার এরকম করে একটু ইন্টারাক্ট করার ব্যাপারটা। ওই ছবি দেখলে এরকম করে দেখে ঝাপসা এসেছে, ছেলে কাঁদছিল, হ্যাঁ, এগুলোকে আউটকাম করে এক্সাক্ট হোয়াট ইজ দি রেডিওগ্রাফ ইজ শোয়িং, ইউ হ্যাভ টু ইভ্যালুয়েট।
হেরিডিটারি স্পেরোসাইটোসিসে কি হচ্ছে, আরবিসি শেপ হয়ে যাচ্ছে স্ফেরিক্যাল। সো if something is spherical and something is biconcave, then if you subject that particular cell or particular thing into a solution, if the solution is hypotonic, which cell can resistant more tonicity for longer time period? Biconcave, of course, because in spherical shape RBC, what is happening? Volume, when water is entering the cell, volume is increasing. And if anything which volume increases and surface area cannot increase, after a certain point of time it will rupture. So these tests is mainly done to see the ability of the RBC to withstand the osmotic fragility when it is subjected to varying grades of hypotonic solution. Okay, so basically the test answer testটা করছে 1 ঘন্টা পর তোরা দেখতে পারবি, ঠিক আছে? আমরা 12টা টেস্ট টিউব নেব। 12টা টেস্ট টিউব নিয়ে কি করব, তোর দুটো জিনিস আমরা নেব, ডিস্টিলড ওয়াটার আর হচ্ছে NaCl। নাও NaCl 0.9% NaCl ইউ মাস্ট রিমেম্বার ইজ আইসোটনিক উইথ প্লাজমা, ঠিক আছে? তাই জন্য আমরা দেখবি যখনই কোনো ফ্লুইড ছড়াই পেশেন্টদের, ইটস অলওয়েজ 0.9% NaCl। তাই জন্য 1% NaCl সলিউশন আমরা নেব, 12টা টেস্ট টিউব নেব, ঠিক আছে? টেস্ট টিউব 1 এ আমরা 22 ড্রপস অফ 1% NaCl দেব, which is equal to 0.88%, so almost 0.9% NaCl। তাহলে ওটা কি হচ্ছে, আইসোটনিক উইথ আরবিসি। 0.88% অফ NaCl এ 22 ড্রপস অফ 0.88% NaCl এ যখন আমরা আরবিসি কে অ্যাড করব, ইট উইল নট রাপচার বিকজ দি সলিউশন ইজ আইসোটনিক উইথ প্লাজমা, ঠিক আছে? আরবিসি ক্যান রিমেইন ইন আইসোটনিক। আইসোটনিক কনসেন্ট্রেশনে কি হবে, কিছুই হবে না, কিছুই হবে না, ইকুয়াল আছে, অ্যাট ইকুইলিব্রিয়াম আছে। তাহলে 0.88% of the NaCl when 1 drop of RBC is subjected, it will withstand the nothing will happen because the solution is isotonic with the level of the RBC with the plasma. তোরা দেখ নাম্বার অফ ডিস্টিলড ওয়াটার দিয়েছে আর নাম্বার অফ 1% স্যালাইন ড্রপ, 12টা কন্ট্রোলে 12 ড্রপ আরবিসি হবে, আরবিসি 12টা ড্রপ হবে, ঠিক আছে? এইবার দেখ পয়েন্ট স্যালাইন ড্রপ, প্রথমে তোরা একটা জিনিস দেখ, ডিস্টিলড ওয়াটার আর স্যালাইন ড্রপ দুটো 12 অব্দি তুই দেখ, দুটো মিলিয়ে 25 ড্রপ হচ্ছে, প্রত্যেকটা দেখ there is 25 drops, which means ভলিউম কিন্তু সবকটাই এক আছে। টনিসিটির গ্রেডটা ডিফারেন্ট হবে, যখন NaCl এর কনসেন্ট্রেশন বেশি হবে আইসোটনিসিটিটা মেনটেন হবে। তারপরে দেখ ধীরে ধীরে সোডিয়াম NaCl এর ড্রপসটা কমছে, NaCl এর ড্রপসটা কমছে মানে কি হচ্ছে, আইসোটনিসিটির কনসেন্ট্রেশনটা কমছে। আর ডিস্টিলড ওয়াটারে দেখ, ডিস্টিলড ওয়াটার 12 যেটা আছে, টেস্ট টিউব 1 will be the control, আর টেস্ট টিউব 12 হচ্ছে দেখ ডিস্টিলড ওয়াটারের হচ্ছে 25 ড্রপস অফ ডিস্টিলড ওয়াটার, মানে কি হবে 25 ড্রপস অফ ডিস্টিলড ওয়াটার ইন টেস্ট টিউব 12, টনিসিটিটা কি হবে, একদম হাইপোটনিক, একদম হাইপোটনিক, ডিস্টিলড ওয়াটারে কোনো টনিসিটিই নেই, একদম হাইপোটনিক। তাহলে 25 ড্রপস আমরা যেটা নিয়েছি, যেটা হচ্ছে টেস্ট টিউব নাম্বার 12, ওটাই কি হওয়া উচিত, আরবিসিটার একদম রাপচার হয়ে যাবে, ঠিক আছে? কেন রাপচার হবে, একদম হাইপোটনিক, হ্যাঁ এন্ডোঅসমোসিস হচ্ছে, ঠিক আছে? এইবার তোদেরকে দেখতে হবে, আমি প্রত্যেকটা ড্রপস ইয়ে করছি না, ঠিক আছে? ভ্যারাইং কনসেন্ট্রেশন দেখ, যখন 22 ড্রপস অফ NaCl আছে তখন 0.88%, মানে ওটা হচ্ছে তোর 0.88% NaCl, টেস্ট টিউব নাম্বার 5 অব্দি দেখ 0.52% অফ দি NaCl, অতটা তোর আরবিসির মেমব্রেন অসমোসিস কিন্তু শুরু হয়ে যাবে। অসমোসিস কিন্তু টেস্ট টিউব 12 থেকে টেস্ট টিউব 2 থেকেই শুরু হয়ে যাবে, যেটা হচ্ছে তোর 16 ড্রপস অফ 1% NaCl, যেটা হচ্ছে তোর 0.64% অফ NaCl। কিন্তু বিকজ অফ দি বাইকনকেভ শেপ অফ দি আরবিসি ইট উইল উইথস্ট্যান্ড দি এন্ডোঅসমোসিস। কতটা অবধি উইথস্ট্যান্ড করবে? টেস্ট টিউব নাম্বার 5 অবধি উইথস্ট্যান্ড করবে। ততটা তোর আরবিসি মেমব্রেন, বাইকনকেভ মেমব্রেন অফ দি আরবিসি উইথস্ট্যান্ড দি এন্ডোঅসমোসিস দ্যাট ইজ অকারিং। 0.5 অবধি তো সেলটা রাপচার করবে না, ঠিক আছে? হ্যাঁ 0.5% অবধি, যেটা হচ্ছে তোর টেস্ট টিউব 5। টেস্ট টিউব 6 এ দেখ তোর 0.48% অফ দি NaCl যেখানে হচ্ছে, ওইটার থেকে তোর আরবিসি মেমব্রেন রাপচার হতে শুরু করবে। Fragility will start from test tube number 6, but still it will not completely rupture. And how will you understand that the RBC has not completely ruptured? Initial test tube tu dekhbi RBC, when you will put the drops of the RBC, it will settle down at the bottom of the test tube as a drop. Points from the 6th number of the test tube, you will see that the color of the solution has started to turn red. The color of the solution has started to turn red, and from test tube number 9 complete endoosmosis hoye jabe, পুরো রাপচার হয়ে যাবে। পুরো দেখবি 6, 7, 8 you can still see tinge red drop at the end of the test tube, একটা দেখবি ডট থাকবে, which means that there is some amount of the RBC which hasn't ruptured yet, but 10, 11, 12 there will be complete dissolve, the RBC will completely rupture and dissolve into the solution. Okay, now in hereditary spherocytosis, what is hereditary spherocytosis? Look, it is a genetic condition. Now RBC, owing to its biconcave shape, you must remember it is a flexible cell. The cell membrane is flexible but biconcave. মাঝের দিকে চ্যাপ্টা আছে, সাইডের দিকে there is extra membrane. So if it isn't flexible, when it is passing through the narrow capillaries in the circulation, mainly you must remember cords of Billroth in spleen, যেইখানে গিয়ে RBC আটকে যায়, যদি flexible na hoy, can it pass through the narrow capillaries? But what is it in the RBC membrane that is supporting this extra membrane that RBC is having? Have you heard about the protein ankyrin, spectrin, band 3 protein? They anchor the RBC membrane. They are responsible for holding the membrane of the RBC intact within the substance of the RBC. Because if somebody is holding you, so otherwise কোনো যদি support না থাকে, when it will pass through the narrow capillaries, it will lose the chunks of the membrane here and there. Okay, something has to be there that is holding the membrane intact, because of which it is able to pass through the narrow capillaries in circulation. This ankyrin, spectrin and mainly band 3 protein are this protein which hold the membrane of the RBC intact. In hereditary spherocytosis, there is genetic defect in the production of this protein. If these protein are not present in the system of a person, will the biconcave shape of the RBC will be maintained? No. So the RBC automatically becomes spherical in shape. RBC automatically becomes spherical in shape. তাই জন্য কি হচ্ছে, spherical যদি হয়ে যায়, a fat person can pass through narrow tunnel? No. তাই জন্য কি হচ্ছে, স্প্লিনে যেখানে তো narrow capillary circulation যেখানেই আছে ওখানে গিয়ে they get stuck, and of course it will not remain stuck there for life. Either macrophages will come, engulf it, extravascular hemolysis, or it will undergo hemolysis because osmosis তো হবেই, withstand করতে পারবে না, নরমালের থেকে বেশি হয়ে যাবে, it will undergo intravascular hemolysis. What are the bad effects of intravascular hemolysis? Intravascular hemolysis হলে কি হচ্ছে, আরবিসির মধ্যে তোর সার্কুলেশনের মধ্যে একটা ম্যাসিভ যদি কারুর হিম অ্যাগ্লুটিনেশন রিঅ্যাকশন হয় বা হিমোলাইসিস হয়, কি হতে পারে, ফ্রি হিমোগ্লোবিন সার্কুলেশনে চলে আসবে। This free hemoglobin is very bad for your organs, mainly for your kidneys. When it passes through the renal capillaries, mainly the renal tubule, it gets precipitated there and will cause renal damage. ঠিক আছে, mast cell will get activated, histamine release হবে, the patient can even go into shock. Okay. Now there are certain things that you must remember. এটা তো তাহলে this is when you are subjecting the RBC to varying grades of isotonic and hypotonic solution. Initial solution, they are isotonic with the RBC membrane, that's why they are not getting ruptured. The later solution, they are becoming the hypotonicity, the degree of the hypotonicity is gradually increasing. Degree of the hypotonicity is gradually increasing and test tube number 12 it is completely hypotonic. তাই জন্য কি হচ্ছে আরবিসিটা তো রাপচার হয়ে যাচ্ছে। এইবার if it is hereditary spherocytosis or if it is hereditary electrocytosis তাহলে যেই রাপচারটা এন্ডোঅসমোসিস তো সেকেন্ড টেস্ট টিউব থেকেই শুরু হচ্ছে, আরবিসি উইথস্ট্যান্ড করছে টিল টেস্ট টিউব 6। হেরিডিটারি সেরোসাইটোসিস যদি হয় ওটা তার আগেই এন্ডোঅসমোসিস হয়ে রাপচার করে যাবে, ঠিক আছে। নাও দেয়ার আর সার্টেন কন্ডিশনস দ্যাট ইউ মাস্ট নো। 5% গ্লুকোজ ইজ আইসোটনিক উইথ প্লাজমা। আমরা 5D ডেক্সট্রোজ চালাই, পেশেন্ট যদি খুব হাইপোগ্লাইসেমিক হয়ে যায় 5% গ্লুকোজ উইল নট কজ এনি প্রবলেম বিকজ ইট ইজ আইসোটনিক উইথ ইয়োর প্লাজমা। কিন্তু যদি তার বেশি চালাই 10% গ্লুকোজ 25D, হাইপোটনিক না হাইপারটনিক? It is hypertonic, but still nothing will happen to RBC. Why? Initially hypertonic solution RBC গেলে কি হবে? Exosmosis হবে। RBC when you are administering 10% glucose or 25D to any patient, initially the RBC will shrink, but glucose of course the cell will metabolize, the cell will utilize the glucose, তাই জন্য কি হবে RBC আবার শেপ রিগেইন করে নেবে।
আচ্ছা 0.9% স্যালাইন সলিউশন তোকে যদি আমি তৈরি করতে বলি, ঠিক আছে, সেটা কিভাবে করবি বল? আমি তোকে যদি বলি 0.9% স্যালাইন সলিউশন তৈরি কর, কিভাবে করবি? কিভাবে কি? ফ্রম ইওর 10+2 নলেজ 0.9% স্যালাইন সলিউশন কতটা জলে কতটা 100 ml এ 0.9 গ্রাম। এটা বলতে এত দেরি? ইউ আর কামিং ফ্রম ফিজিক্স কেমিস্ট্রি ব্যাকগ্রাউন্ড, ঠিক আছে, আমি অনেক আগে পড়েছি। আচ্ছা তাহলে 100 ml এ 0.9 গ্রাম সোডিয়াম ক্লোরাইড দিচ্ছি, ঠিক আছে। আচ্ছা সোডিয়াম ক্লোরাইডের ইয়ে কত মাস? 58.5, তাই তো? 58.5 35.5 প্লাস 23 58.5। তাহলে 0.9 grams of sodium chloride is equivalent to 0.9 divided by 58.5 gram moles, ঠিক আছে, 58.5 gram moles, ওকে। আচ্ছা এবার একটা ফর্মুলা আছে ভ্যান হফস ইকুয়েশন RT5IC, ঠিক আছে। তাহলে এখানে এই গ্রাম মোলার ওয়েটটা দিলেই অসমোলারিটিটা ক্যালকুলেট হয়ে যাবে, ঠিক আছে। ফাই এর ভ্যালু হচ্ছে 0.93 সোডিয়ামের জন্য, ঠিক আছে। তাহলে ওটা আসবে, দেখবি ক্যালকুলেট করে আসবে অ্যারাউন্ড 289 সামথিং, আস 289 পয়েন্ট সামথিং এরকম একটা আসবে, মানে 290 আমাদের। তার মানে 0.9% যে স্যালাইন সলিউশনটা সেটা ব্লাডের অসমোলারিটির সঙ্গে সেম, ঠিক আছে। তার মানে 0.9% সলিউশন আমি যদি ব্লাডে মিশিয়ে দিই, 0.9% স্যালাইন সলিউশন যদি ব্লাডে মিশিয়ে দিই, দেয়ার উইল বি নো চেঞ্জ ইন শেপ অফ আরবিসিস, একই রকম থাকবে, ঠিক আছে। মানে অসমোসিস হয়ে আরবিসির ভেতরের ফ্লুইড বাইরেও যাবে না বা বাইরের ফ্লুইড ভেতরেও আসবে না, ঠিক আছে, বিকজ দ্য ফ্লুইড ইজ আইসোটোনিক। নাও হোয়াট উইল হ্যাপেন ইফ আই ইনফিউজ 3% saline? What will happen if I infuse 3% saline to the patient? Hypertonic solution, এর অসমোলারিটি অনেক বেশি। যাই হোক এখানে RT5IC করে ক্যালকুলেট করে দেখবি তার অসমোলারিটি এখানে 500-600 ছাড়িয়ে যাচ্ছে, ঠিক আছে। তাহলে সেই সলিউশন যদি পেশেন্টকে দেওয়া হয় কি অসুবিধা হবে? কি হবে? আরবিসি শ্রিঙ্ক করবে, ঠিক আছে, আরবিসি সেল ক্রিনেশন হবে, ঠিক আছে। আচ্ছা তাহলে আমরা ইন মোস্ট অফ দ্য ক্লিনিক্যাল কেসেস উই উইল ইনফিউজ 0.9% saline to the patient unless otherwise indicated, ঠিক আছে। কিন্তু এটাও ইউজ হয়, 3% স্যালাইনও ইউজ হয়। কখন ইউজ হয় সেটা তো জানার কথা নয়। হাইপোনাট্রিমিয়া, সোডিয়াম কমে গেলে, সিভিয়ার হাইপোনাট্রিমিয়া হলে আমরা 3% স্যালাইন সলিউশন পেশেন্টকে দিই, ঠিক আছে। কিন্তু তার একটা রিস্কও থাকে, ঠিক আছে। 3% স্যালাইন সলিউশন পেশেন্টকে যখনই দিতে হয় খুব স্লো দিতে হয়। কেন স্লো দিতে হয়? not for cell clination হয়ে যাবে বিকজ আমরা খুব কম দিই, মানে 3% স্যালাইন সলিউশন দিয়ে 100 ml ছোট ছোট বোতল থাকে, ঠিক আছে। নর্মাল স্যালাইনের বোতল হাতে নিয়ে দেখেছিস তো 500 ml, ঠিক আছে। 3% স্যালাইন সলিউশন হাতে নিয়ে দেখবি ছোট ছোট বোতল, ঠিক আছে। এটাও পেশেন্টকে দেওয়া হয়। কখন দেওয়া হয়? হাইপোনাট্রিমিয়া হলে, সিভিয়ার হাইপোনাট্রিমিয়া হলে দেওয়া হয়। এবার হাইপোনাট্রিমিয়া আবার অনেক রকম আছে, আইসোভলিউমেট্রিক হাইপোনাট্রিমিয়া, হাইপারভলিউমিক হাইপোনাট্রিমিয়া, হাইপোভলিউমিক হাইপোনাট্রিমিয়া, সব রকম আছে। সেগুলো ডিটেলসে পরে পড়াবো, ঠিক আছে, ডিউরিং ভলিউম রেগুলেশন ক্লাস, যেটা ইয়েতে কিডনিতে আছে, ঠিক আছে। রেনাল সিস্টেম শুরু হয়নি এখনো, শুরু হয়েছে? আচ্ছা আচ্ছা, স্যার শুরু করেছেন তাই তো, এইচওডি স্যার শুরু করেছেন, বেশ ঠিক আছে। তো ওখানে ডিটেলসে পড়তে হবে কিরকম ধরনের হাইপোনাট্রিমিয়া। এনিওয়ে, when there is severe hyponatremia means নর্মাল সোডিয়াম কনসেন্ট্রেশন কত ব্লাডে, অনেকটা চলে আসছে, এবার দেখাবো, ঠিক আছে। নর্মাল স্যালাইন সলিউশন কত, নর্মাল সোডিয়াম কনসেন্ট্রেশন, আরে এগুলো তো জানতেই হবে, নর্মাল সোডিয়াম কনসেন্ট্রেশন কত, পটাশিয়াম কনসেন্ট্রেশন কত, ব্লাডের অসমোলারিটি কত, এগুলো জানতে হবে। নর্মাল সোডিয়াম কনসেন্ট্রেশন ইজ 136 to 145 মিলি ইকুইভ্যালেন্ট পার লিটার, ঠিক আছে। প্রতি লিটার ব্লাডে 136 থেকে 145 মিলি ইকুইভ্যালেন্ট সোডিয়াম আছে, ঠিক আছে। পটাশিয়াম কত আছে, 3.5 থেকে 5.5 মিলি ইকুইভ্যালেন্ট পার লিটার, ঠিক আছে। আচ্ছা, তাহলে ব্লাডে অসমোলারিটি কে ডিটারমাইন করছে, অসমোলারিটি কার জন্য হচ্ছে, কোন আয়নের জন্য হচ্ছে, এতক্ষণ তো এটাই তো বুঝলি, সোডিয়ামের জন্য। ইজ দেয়ার এনিথিং এলস যেটা ব্লাডের অসমোলারিটি বাড়াতে পারে বা কমাতে পারে? পারে, in true sense পারে, potassium will change osmolarity, but do we consider it? No, because potassium concentration is very less, ঠিক আছে। পটাশিয়ামের কনসেন্ট্রেশন কোথায় বেশি, ভেতরে, সেলের ভেতরে, ইন্ট্রাসেলুলার কম্পার্টমেন্টে, ঠিক আছে। এক্সট্রা সেলুলার কম্পার্টমেন্টে সোডিয়ামের কনসেন্ট্রেশন বেশি, 136, এখনই বললাম 136 to 145 মিলি ইকুইভ্যালেন্ট পার লিটার। সেখানে পটাশিয়াম হচ্ছে 3.5 to 4.5, 3.5 to 5.5 মিলি ইকুইভ্যালেন্ট পার লিটার। এটা এতটাই কম যে এটাকে আমরা ইউজুয়ালি নেগলেক্ট করি, আনটিল এন্ড আনলেস দেয়ার ইজ সিভিয়ার হাইপারক্যালেমিয়া। অত হাইপারক্যালেমিয়া হলে পেশেন্ট বাঁচেও না, সেটা আলাদা কথা, ঠিক আছে। তো যাই হোক, পটাশিয়ামকে আমাদের ইন ডে টু ডে প্র্যাকটিস, পটাশিয়ামের কন্ট্রিবিউশন ইন রেজিং ব্লাডস অসমোলারিটি ইজ ইনসিগনিফিকেন্ট, ঠিক আছে। ওকে, তাহলে ব্লাডের অসমোলারিটি কোন কোন জিনিস কন্ট্রিবিউট করে, ঠিক আছে। আচ্ছা, অসমোলারিটি বেড়ে গেছে, ব্লাডে অসমোলারিটি বেড়ে গেছে, এরকম কিছু কেস বলতে পারবি, কোন পেশেন্টের অসমোলারিটি বেড়ে যাবে ইন আওয়ার ডে টু ডে প্র্যাকটিস, ঠিক আছে। ডিহাইড্রেশন হলে, ওকে, হেমারেজের ফলে, ঠিক আছে। ডিহাইড্রেশন হলে টু সাম এক্সটেন্ট অসমোলারিটি চেঞ্জ হতে পারে ইমিডিয়েটলি, বাট ইট উইল বি কম্পেনসেটেড ইমিডিয়েটলি, ঠিক আছে, বিকজ অফ ফ্লুইড শিফট ফ্রম ইন্টারস্টিশিয়াল ফ্লুইড টু ইন্ট্রাভাস্কুলার কম্পার্টমেন্ট, ঠিক আছে। মোস্ট ইম্পর্টেন্ট এক্সাম্পল ইজ ডায়াবেটিস, ঠিক আছে। কেন? বিকজ অফ সিম্পলি গ্লুকোজ বেশি আছে, ঠিক আছে। আচ্ছা, অসমোলারিটি হচ্ছে এমন একটা প্রপার্টি যেটা দ্যাট ডিপেন্ডস অন দি নাম্বার অফ পার্টিকেল। এটাকে কি প্রপার্টি বলে? কলিগেটিভ প্রপার্টি, অ্যাভোগাড্রো নাম্বার, ঠিক আছে। সো দিস ইজ অসমোলারিটি ইজ এ কলিগেটিভ প্রপার্টি, মানে এটা ডিপেন্ড করে না যে কত গ্রামস আছে, ডিপেন্ড করে কত গ্রাম মোলস আছে, ঠিক আছে, কত গ্রাম মোলস আছে, ঠিক আছে। যেমন এই যে আচ্ছা, তোকে যদি আমি একটা এক্সাম্পল দিচ্ছি, মনে কর 1 লিটার ওয়াটার, 1 লিটার জল, ঠিক আছে। 1 লিটার জলে আমি যদি 1 গ্রাম মোলস অফ সোডিয়াম ক্লোরাইড সলিউশনে দিয়ে দিই, 1 লিটার জল, তাতে 58.5 গ্রামস অফ সোডিয়াম ক্লোরাইড সলিউশনে দিয়ে দিলাম, ঠিক আছে। এই সলিউশনের অসমোলারিটি কত হবে? সিম্পল কোশ্চেন, বল। What will be the osmolarity of the solution if I dissolved 58.5 grams of sodium chloride in 1 liter of water? How much will be of? Very nice. Kano? NaCl. So Avogadro number of sodium and Avogadro number of chloride. ঠিক আছে? So the concentration is 2 osmoles. ঠিক আছে? Clear? So similarly, if I dissolve calcium chloride, 1 gram moles of calcium chloride, 3. ঠিক আছে? আচ্ছা, তাহলে ব্লাডের অসমোলারিটি ডিপেন্ড করে এর মধ্যে সোডিয়াম ক্লোরাইড আছে, ঠিক আছে। তাহলে আমরা সোডিয়ামের যে মানে সোডিয়ামের জন্য যেটা হচ্ছে সেটাকে আমরা ডাবল করলেই অসমোলারিটি পেয়ে যাবো, ক্লোরাইডটা আলাদা করে ধরছি না। গেটিং মাই পয়েন্ট? সেই জন্য ব্লাডের অসমোলারিটির ফর্মুলা হচ্ছে, অলওয়েজ রিমেম্বার, আমরা বেড সাইড ক্লিনিক্সে অলওয়েজ পেশেন্টের অসমোলারিটি কত আছে সেটা জানার জন্য এই ফর্মুলাটাই ইউজ করি, ঠিক আছে। অ্যান্ড দ্য ফর্মুলা ইজ 2 into Na+, ঠিক আছে, 2 into Na+ দে। সো দ্য ফর্মুলা ইজ, সবাই মুখস্থ করবে এই ফর্মুলা, এই ফর্মুলা না জানলে 2 into Na plus in milli equivalent per liter, ঠিক আছে, 2 into Na plus in milli equivalent per liter, right, plus glucose in the unit of milligram per deciliter divided by 18, ঠিক আছে, গ্লুকোজের 180 হয়, ওই জন্য কাটাকাটি হয়ে 18 আসছে, ঠিক আছে। আচ্ছা, আর গ্লুকোজ ব্রেক করে না, ঠিক আছে, ওর একটাই মলিকুলটা ব্রেক করে না, ঠিক আছে, প্লাস ব্লাড ইউরিয়া নাইট্রোজেন BUN again in milligram per deciliter, milligram per deciliter divided by 2.8, ঠিক আছে। এইটা যদি করা হয় তাহলে সেরাম অসমোলারিটি আসবে, ঠিক আছে, ব্লাডের অসমোলারিটি কত সেটা চলে আসবে। ওকে, মনে কর সিম্পলি এখান থেকে ক্যালকুলেট করি না, মনে কর কোনো একটা পেশেন্টের, ঠিক আছে, তাহলে দিস ইজ সেরাম অসমোলারিটি 2 Na প্লাস, ঠিক আছে, 2 Na প্লাস প্লাস গ্লুকোজ কনসেন্ট্রেশন ইন মিলিগ্রাম পার ডেসিলিটার, বিকজ আমরা ল্যাবরেটরিতে যা গ্লুকোজের কনসেন্ট্রেশন মাপি দ্যাট ইজ নট ইন মিলিমোল, দ্যাট ইজ ইন মিলিগ্রাম পার ডেসিলিটার, ঠিক আছে। ল্যাব আমাদেরকে যে ভ্যালু দেয় সেটা হচ্ছে মিলিগ্রাম পার ডেসিলিটার, যেটা কনভেনশনালি আমরা ইউজ করি, ঠিক আছে। এখন অবশ্য কোনো ভালো ল্যাবরেটরিগুলো মিলিমোলেও লিখে দিচ্ছে, এনিওয়ে দ্যাট ইজ ডিফারেন্ট, বাট কনভেনশনালি থ্রু আউট দ্য ওয়ার্ল্ড ইন মোস্ট অফ দ্য ল্যাবরেটরিজ দে ইউজ মিলিগ্রাম পার ডেসিলিটার ইউনিট ফর সেরাম গ্লুকোজ, রাইট। সো সেরাম গ্লুকোজ মনে করে এসছে কোনো ডায়াবেটিক পেশেন্ট, তার ব্লাড গ্লুকোজ মনে কর পেশেন্টটা আনকনসাস আছে, ঠিক আছে, পেশেন্টটা আনকনসাস আছে, তুই সিম্পলি একটা সিবিজি করে দেখলি, আঙুলে পিন ফুটিয়ে একটা সিবিজি করে দেখলি যে গ্লুকোজ আছে 600, ঠিক আছে, তাহলে পেশেন্টের অসমোলারিটি কত, তোকে যদি বলা হয় পেশেন্টের অসমোলারিটি কত, তুই দেখলি পেশেন্টের সোডিয়াম আছে 136, ঠিক আছে, তাহলে 2 into 136, ঠিক আছে, প্লাস গ্লুকোজ আছে দেখলি 600 600 বাই 18, ঠিক আছে, প্লাস ইউরিয়া, ব্লাড ইউরিয়া নাইট্রোজেন, ইউরিয়া মনে কর 40 আছে, ঠিক আছে, বা 28 আছে ধর, তাহলে সুবিধা হবে হিসাব করতে, হ্যাঁ, বাই 2.8, তাহলে দেখ এর 136 মানে 172 প্লাস 3 18 354, ও সরি 272, হ্যাঁ 272, হ্যাঁ 272 54 60 18 এগেন 33, ঠিক আছে 33 ধর প্লাস 10, ঠিক আছে, তাহলে 272 282 প্লাস 33, মানে 300-র উপর কোথাও একটা এর, হ্যাঁ, মানে 310 অ্যারাউন্ড 310 এর অসমোলারিটি হবে, মানে অসমোলারিটি বেড়ে বসে আছে, ঠিক আছে, পেশেন্ট আনকনসাস, ঠিক আছে, অসমোলারিটি বেড়ে আছে, ব্রেন সোয়েলিং হয়ে গেছে, পেশেন্ট আনকনসাস, ঠিক আছে, এটাই হয় ডায়াবেটিক কোমাতে, ঠিক আছে, ডায়াবেটিক কোমার পেশেন্ট দেখবি যাই হোক এটাই হয়, ঠিক আছে, অসমোলারিটি বেড়ে গেছে, এবার তুমি ট্রিটমেন্ট করো, ইনসুলিন দাও, পটাশিয়াম দাও, যা হোক দাও, ট্রিটমেন্ট করো, ট্রিটমেন্ট ইজ নট মানে ফর দ্য টাইম বিং নট ইউর জব, ঠিক আছে। এখন আমাদের ডিজিজ প্যাথোলজিগুলো জানতে হবে যে কিভাবে হচ্ছে, কেন হচ্ছে, ডায়াবেটিক কোমার পেশেন্ট আনকনসাস, কেন আনকনসাস, অসমোলারিটি বেড়ে আছে, ব্রেনের সেলগুলো সোয়েলিং হয়ে আছে, ঠিক আছে, তো এইরকম ব্যাপার, বোঝা গেছে। ওকে, সো এইভাবে আমরা অসমোলারিটি ক্যালকুলেট করব, ঠিক আছে। এবার আরেকটা কেস বলছি তোদের, খুব ইম্পর্টেন্ট কেস, পেপারে পড়েছিস, দেশি মদ খেয়ে মৃত্যু, দেখেছিস তো, হ্যাঁ, কেন মরলো, কেন, মদ তো সবাই খায়, দেশি, আচ্ছা দেশি হলে কি প্রবলেম আছে, মিথানল, ইথাইল অ্যালকোহলের জায়গায় মিথাইল অ্যালকোহল আছে, ঠিক আছে, নর্মালি যেটা মানে পিউরিফাইড অ্যালকোহল ফর হিউম্যান কনজাম্পশন যেটা হয় সেটা হচ্ছে ইথাইল অ্যালকোহল, ঠিক আছে, ভদকা হুইস্কি যা হোক সেগুলো হচ্ছে ইথাইল অ্যালকোহল, ঠিক আছে। আচ্ছা, দেশি মদ মানে ওখানে অ্যাডাল্টারেন্স আছে, কি আছে, মিথাইল অ্যালকোহল আছে, ঠিক আছে। নাও দ্য প্রবলেম ইজ দিস মিথাইল অ্যালকোহল, মিথাইল অ্যালকোহল কি করেছে, অসমোলারিটি বাড়িয়েছে, ঠিক আছে, গ্লুকোজ C2H5O মানে C6H12O6 যেরকম অসমোলারিটি বাড়ায় সেরকম C2H5OH CH3OH এটাও অসমোলারিটি বাড়ায়, ঠিক আছে। ইথাইল অ্যালকোহল বাড়াতে পারে না, বিকজ তার আগে অনেক অন্যরকম ভাবে মেটাবোলাইজ হয়ে যায়, ঠিক আছে, তার আগেই মেটাবোলাইজ হয়ে যায়। আচ্ছা, তাহলে মিথাইল অ্যালকোহল আমার অসমোলারিটি বাড়িয়েছে, ঠিক আছে। নাও তুই হসপিটালে ইমার্জেন্সি ডিউটি করছিস, ঠিক আছে, দেশি মদ খেয়ে অজ্ঞান 5-6 জন পেশেন্ট এসছে, নাও তুই জানিস না, ঠিক আছে, তুই জানিস না কি মোড অফ পয়জনিং কি, হয়তো কিছুটা গন্ধ পেয়ে কিছুটা বুঝতে পারছিস, ঠিক আছে, মোড অফ পয়জনিং কি কিছু জানিস না। নাও you have thought of calculating osmolarity of the patient. Put the formula, 2 sodium, glucose by 18, blood urea nitrogen by 2.8, normal, 290, it is coming 290, and you are thinking osmolarity is normal. because we are not considering C2H5 CH3OH here. ঠিক আছে, আমরা মিথাইল অ্যালকোহল এখানে কনসিডার করিনি, যেটা অসমোটিক্যালি অ্যাক্টিভ সাবস্টেন্স, যেটা ব্লাডের অসমোলারিটি বাড়াবে। ঠিক আছে, তাহলে দিস ফর্মুলা ইজ ট্রু ইন অল দ্য কেসেস, ইন কিটোঅ্যাসিডোসিস, ইন diabetic ketoacidosis, in dehydration, in any of the condition, whatever be the cause of coma, right? You consider this formula for calculating patient's osmolarity, but not in a case of poisoning. Okay, so what will you do in case of poisoning? Next question is how to calculate osmolarity in case of poisoning. Yes, in this patient, in methyl alcohol poisoning patient, osmolarity, it should be high, it should be more than 350 or more than 300, right? It should be high, as because the patient is unconscious, okay, as because the patient is unconscious, there is some changes in the brain cells, right? Patient is unconscious and osmolarity must be high, but if you are putting this formula, osmolarity is normal, so we cannot use this formula, right? So you need to check patient's osmolarity by some different method. What is that method? Osmolarity is one colligative property. Tell another colligative property of a substance. Another colligative property. What are other colligative properties? Freezing point depression. Freezing point depression. Okay. Freezing point depression. Very nice. Okay. So for every one osmol of solution extra that is mixed in blood, freezing point depression will be 0.30206. ঠিক আছে, 0.30206, normally 0 degree, ঠিক আছে, 0.30206. okay, this line has been written in Ganam, right? 0.30206. now you calculate freezing point depression, okay, and divide it by this and you will get the osmolarity, right? No need to consider sodium, glucose, or methyl alcohol, ethyl alcohol, whatever has been mixed in blood. You apply the formula of freezing point depression, how much is the freezing point and how much it is below 0 degree, and you divide it with 0.30206, right? And you get the osmolarity. Clear? Okay. Because for every 1 milliosmol you get this much depression of freezing point. So say for example minus 0.54 is the freezing point. So minus 0.54 by 0.000206 is you get the osmolarity of blood, right? So something and you are using this formula and you are getting 290, right? You are using this formula 2Na plus glucose by 18 plus blood urea nitrogen by 2.8 and you are getting 290. So it is normal. And when you are using freezing point depression method, you are getting 310. Osmolarity is high and this is actual, right? So there is a gap with the formula we apply at the bedside clinics because for freezing point depression you need a machine, right? Freezing point depression calculator, you need a machine, right? Okay. So at the bedside you have some laboratory investigation, you have sodium report of the patient, you have glucose report of the patient, you have urea creatinine report of the patient, so everything you have, and you are applying this formula and you are getting 290, and when you are using freezing point machine you are getting 310. So there is a gap of 20 milliosmol and this is called osmotic gap. Sequence of solution, okay, everywhere it is 25 drops, ঠিক আছে, ওই বইটা করে দে, বার কর ওখানে অসমোটিক ফ্যাসিলিটিটা বার কর, ওই টেবিলটা বার কর, একটা টেবিল আছে, হ্যাঁ পেয়েছিস, তাই তো, ওকে, তাহলে এই টেবিলটা কাউকে মুখস্থ রাখতে হবে না, নো নিড টু রিমেম্বার, এই টেবিলটা দেওয়া থাকবে, ঠিক আছে। আচ্ছা, তাহলে এখানে আমরা সবসময় 25 ড্রপস দেবো, প্রত্যেকটা টিউবে 25 ড্রপস করে দেবো, ঠিক আছে, প্রত্যেকটা টিউবে 25 ড্রপস করে দেবো। এখানে আমার 12টা ইয়ে আছে, টেস্ট টিউব আছে, ঠিক আছে, সেগুলো নাম্বারিং করা আছে 1 2 3 4 5 6 7 8 9 10 করে সব কটা নাম্বারিং করা আছে, ঠিক আছে। তাহলে ফার্স্ট আমি কি করব, ফার্স্ট যে টেস্ট টিউবটা সেখানে আমি ডিস্টিল ওয়াটার দিয়েছি 3 ড্রপ আর সেলাইন দিয়েছি 22 ড্রপস, মানে টোটাল কত ড্রপ দিলাম, 25 ড্রপস, and it will create a solution that is 0.88%. So almost 0.9%. So we can consider it normal saline. ঠিক আছে, তাহলে প্রথমটাতে নর্মাল স্যালাইন আছে, ঠিক আছে, প্রথমটাতে 1 নম্বরটাতে নর্মাল স্যালাইন আছে, একটু ইয়ে হয়েছে এদিক ওদিক হয়েছে হয়তো, যাই হোক ঠিক আছে, নর্মাল স্যালাইন আছে, রাইট, নর্মাল স্যালাইন আছে। তারপরেরটাতে আমি 9 ড্রপস দিয়েছি ডিস্টিল ওয়াটার আর 16 ড্রপ দিয়েছি again 25 drops, but concentration is decreasing definitely because saline drop কমিয়ে দিয়েছি, জলের ড্রপ বাড়িয়ে দিয়েছি, তাহলে কনসেন্ট্রেশন কমে যাচ্ছে 0.64, ঠিক আছে। তারপরটাতে আমি 10টা ড্রপ দিয়েছি ডিস্টিল ওয়াটার আর 15টা ড্রপ দিয়েছি স্যালাইন, 0.6%, ঠিক আছে। তাহলে এইভাবে আমি আস্তে আস্তে ডিস্টিল ওয়াটারের ড্রপ বাড়িয়ে যাচ্ছি আর স্যালাইনের ড্রপ কমিয়ে যাচ্ছি, ঠিক আছে। তাহলে আস্তে আস্তে সলিউশনটা হাইপোটোনিক হয়ে যাচ্ছে, তাহলে 1 থেকে 12 অবধি আস্তে আস্তে স্যালাইনটা মানে সলিউশনটা হাইপোটোনিক হয়ে যাচ্ছে, ঠিক আছে। তাহলে হাইপোটোনিক হয়ে যাচ্ছে, এবার আমি প্রত্যেকটাতে 1 ড্রপ করে ব্লাড দিয়ে দিয়েছি, ঠিক আছে। তাহলে এটা তো নর্মাল স্যালাইন, এখানে হিমোলিসিস হবে না, ঠিক আছে, এখানে ব্লাড নর্মালি থাকবে। এবার একটা পয়েন্ট আসবে যেখানে হিমোলিসিস হয়ে যাবে, গোটা সলিউশনটা একটা পিঙ্কিশ হয়ে যাবে, ঠিক আছে। তাহলে এইখান থেকে মোটামুটি স্টার্ট হয়েছে, 6 নম্বর থেকে স্টার্ট হয়েছে, ঠিক আছে। এটা আরেকটু রাখতে হবে, এখনো মানে ফুল এটা হয়নি, ঠিক আছে। তাহলে হ্যাঁ, তাহলে প্রথম থেকে এই 1 নম্বরটা একটু গন্ডগোল হয়েছে মেশানোটা, যাই হোক, হ্যাঁ দেখ 6 নম্বর থেকে শুরু হয়েছে, ঠিক আছে। এইরকম জায়গায় এসে হিমোলিসিসটা কমপ্লিট হয়ে গেছে, ঠিক আছে। এখানে আরবিসি গুলো ভাঙতে শুরু করেছে, এইখানে এসে আরবিসি গুলো ব্রেকডাউন একদম কমপ্লিট হয়ে গেছে, ঠিক আছে। তাহলে 6 নম্বরটাতে হচ্ছে হিমোলিসিস শুরু হচ্ছে, তাহলে 6 নম্বরটাতে কনসেন্ট্রেশন কত আছে দেখ 0.48%, তাহলে 0.48% শুরু হলো আর মোটামুটি 0.36% এখানে আমার হিমোলিসিস কমপ্লিট হয়ে গেল, ঠিক আছে। এটাই ডেমনস্ট্রেশন করা, ঠিক আছে। এটা নর্মাল, এটা নর্মাল হেলদি ইন্ডিভিজুয়ালের ব্লাড দিয়ে, ঠিক আছে। তাহলে নর্মালি 6 নম্বর টেস্ট টিউবে আমার আরবিসি গুলো ভেঙে যাচ্ছে, ঠিক আছে। মানে অ্যাকচুয়ালি হাইপোটোনিক স্যালাইনে হাইপোটোনিক সলিউশনে কি হবে, হাইপোটোনিক সলিউশনে দিলে আমার আরবিসি গুলো আস্তে আস্তে সোয়েলিং হবে, হয়তো হবে তো আরবিসি গুলো সোয়েলিং হবে, আরবিসি গুলো সোয়েলিং হতে হতে একসময় বাস্ট করবে, ঠিক আছে। এবার কখন বাস্ট করবে দ্যাট ডিপেন্ডস অন দি রেজিলিয়েন্স অফ দি মেমব্রেন, সেল মেমব্রেন কতক্ষণ ওকে ধরে রাখতে পারছে, সেল মেমব্রেনের রেজিলিয়েন্সের উপর ডিপেন্ড করবে, রাইট। So a point will come when cell membrane will not be able to accommodate this much amount of fluid within the RBC and it will rupture, right, and that point is 0.48%, okay, that point is 6 নম্বর টেস্ট টিউবটা যেটাতে 0.48% স্যালাইন রয়েছে, হাইপোটোনিক ডেফিনেটলি 0.9 নরমাল, 0.48 হাইপোটোনিক, ঠিক আছে। তাহলে এইখানে এসে আরবিসি গুলো ভেঙে যাচ্ছে, রাপচার করা শুরু হচ্ছে আর কি, ঠিক আছে। আচ্ছা, এবার আমি কোনো একটা পেশেন্টের ব্লাড নিয়ে করলাম, দেখলাম 2 নম্বরটাতেই ভেঙে গেল, মানে কি প্রবলেম আছে, হ্যাঁ হ্যাঁ অসমোটিক ফ্র্যাজিলিটি ইজ হাই, ঠিক আছে, অসমোটিক ফ্র্যাজিলিটি ইজ হাই, ঠিক আছে। ফ্র্যাজিলিটি হাই মানে তাড়াতাড়ি রাপচার করবে, ঠিক আছে, একটু হাইপোটোনিক করলেই রাপচার করে যাবে, ঠিক আছে। তাহলে সেটা কি এক্সাম্পল হচ্ছে হেরিডিটারি স্পেরোসাইটোসিস, সাম প্রবলেম ইন দি মেমব্রেন, ঠিক আছে, মেমব্রেনের রেজিলিয়েন্সের প্রবলেম হয়ে গেছে। কেন হয়েছে? বিকজ অফ মেমব্রেন প্রোটিনস গুলোর কিছু মিউটেশন হয়েছে, গন্ডগোল হয়েছে, ঠিক আছে। হেরিডিটারি স্পেরোসাইটোসিস তোরা জানিস অ্যাঙ্কাইরিন, পেকটিন, ব্যান্ড 3, ঠিক আছে, এই প্রোটিনগুলোর মিউটেশন হয়, ঠিক আছে। তাহলে একটা এক্সাম্পল দিতে হবে, এই মানে এটা থেকে যদি কোশ্চেন জিজ্ঞেস করে তাহলে জিজ্ঞেস করবে যে গিভ মি অ্যান এক্সাম্পল অফ ওয়্যার অসমোটিক ফ্র্যাজিলিটি ইজ হাই, ঠিক আছে, মানে সহজে ব্রেক করে যাচ্ছে, ঠিক আছে। আবার অনেক সময় সহজে ব্রেক করে না, যেমন সিকেল সেল অ্যানিমিয়া সহজে ব্রেক করে না, ঠিক আছে, সেটাও সেরকমও থাকবে, ওকে ওকে। তাহলে একটা এক্সাম্পল হেরিডিটারি স্পেরোসাইটোসিস, এলিপ্টোসাইটোসিস সবই যেগুলোতে মেমব্রেন ডিফেক্ট, মেমব্রেনের ডিফেক্ট মানেই তাড়াতাড়ি ব্রেক করে যাবে, ঠিক আছে, ও রেজিস্ট করবে না, ওকে, ঠিক আছে। সো দিস ইজ আ সিম্পল টেস্ট বাই হুইচ উই ক্যান সিম্পলি অ্যাট দি বেডসাইড we can determine if the patient is having high osmotic fragility, or if you suspect hereditary spherocytosis in a patient, just simply bedside you can perform this test, ঠিক আছে। পেশেন্ট আছে, পেশেন্টের পাশেই 12টা টেস্ট টিউব নিয়ে আমরা এটা ইজিলি পারফর্ম করতে পারি, ওকে ক্লিয়ার। অসমোটিক ফ্র্যাজিলিটি টেস্ট এটা পরীক্ষায় করতে হবে না তোমাদের, ইট ইজ এ নন পারফরমেন্স টপিক, বাট ইটস এ ডেমনস্ট্রেশন টপিক, আমরা ডেমনস্ট্রেশন করে তোমাদের দেখিয়ে দেবো, বাট ইউ উইল ফেস কোশ্চেন্স ফ্রম ইট, ঠিক আছে। দিস ইজ এ নন পারফরমেন্স টপিক। তোদের প্র্যাকটিক্যালি নন পারফরমেন্স টপিক কি আছে যেগুলো পারফর্ম করতে হবে না, কিন্তু সেখান থেকে কোশ্চেন আসবে, ভালোই কোশ্চেন আসবে। ইএসআর আছে, প্যাক্সেল ভলিউম আছে, অসমোটিক ফ্র্যাজিলিটি টেস্ট হলো, এরপরে পালমোনারি ফাংশন টেস্ট আছে, ঠিক আছে, স্পাইরোমেট্রি আছে, তারপরে ইসিজি আছে, তোদের করতে হবে না। বাট ইসিজি স্টিল ইট ইজ নন পারফরমেন্স টপিক, বাট ইউ শুড নো, ঠিক আছে। বাড়ির যে কারো করতে হতে পারে, যখন খুশি করতে হতে পারে। হাউ টু অ্যাটাচ দি ক্লিপস, ঠিক আছে, কোন লিম্বে লাগাবো, কোন কালারটা কোথায় যাবে, চেস্ট লিডগুলোর কানেকশন কি, সবকিছু জানতে হবে, ঠিক আছে, ওকে। আর ইসিজি তো ইন ডিটেলস জানতেই হবে, বাকি মানে গ্রাফটা ইন্টারপ্রিট করা জানতেই হবে, ওকে। চল আর একটু ওয়েট করে দেখে যেতে পারিস, নাহলে চলে যেতে পারিস, বুঝে তো গেছিস নাকি বাস আবার কি।
Okay, and the third one is the inferior mesenteric. So tell me what would be the definition? What would be the definition of the celiac artery? So this is, write it down, what is the definition of celiac artery? This is the anterior unpaired branch coming from the abdominal aorta, which supply the oral cavity up to the second part of duodenum. In bracket you write foregut. Okay, oral cavity to the second part of duodenum, that is the foregut. So now next question is, what is the vertebral level? Okay, so at first I told you what is the extension of abdominal aorta. Write it down. Extension of abdominal aorta kotha theke kothay bol? So if you say abdominal aorta, right, extension kothay? T12 to L4, not 5. বুঝতে পারলি? L4 এ it will complete. Okay, T12 to L4. L4 এ গিয়ে কি হয় abdominal aorta? It will bifurcate into two common iliac artery. Okay, so this is the bifurcation, this is the vertebral level. So what about the celiac trunk? From where it will start? Okay, it's a very minute small branch. You won't even see in many cadaver. Okay, it is missing. And how you will trace? It is guarded by two structure. One is the stomach and another one is the liver, inferior part of liver. Okay, so you write what is the vertebral level for the celiac artery. Okay, so write it down. You have written this one. So now we will come across what are the branches we are having. Okay, so first one, write it down. So see, celiac, this is also the this spelling is also right. Another one, if you are right, CELIAC, that is also correct. But you go for this one. Okay. So if you say the celiac artery, what is the branch? How many branches do you know? There are 3 major branches. So which are they? So first one is, you have to say left gastric. Okay. This, which one is the smallest branch? সবথেকে ছোট branch কোনটা? সবথেকে largest. This left gastric is the smallest. Okay, left gastric is the smallest. Then you are having common hepatic and third one is the splenic. So vertebral level is, write it down, it is T12. Eta MCQ আছে T12. Okay. Then if you say celiac artery, we will have main 3 branches. So what are the 3 branches? Number 1 is left gastric. Okay. Then second one we are having, that is the common hepatic. So why you are saying common hepatic? Is it only supplying the liver or else any other organ? আর কি কি সাপ্লাই করে বল? লিভার কে দিয়ে দিল, রাইট? আর কাকে সাপ্লাই করে? It is also supplying the gallbladder, even it is also supplying the stomach, some part. Okay, gastroduodenal যেটা আছে. Okay, so common hepatic and the third one is the splenic. Okay, so these are the 3 branches. Okay, so this is the 3 branches. Now we will come one by one. What are the relation? How does it come out? So what I told, write it down. It is coming out at the vertebral level of T12 and it is guarded by which viscera? One is the stomach, another one is the inferior surface of liver. So write it down. It is guarded by the inferior surface of liver and the stomach. So suppose in the dissection, if you are going from outside to inside, first viscera you have to move the inferior surface of the liver. Okay, then you will get what? The stomach. Then you have removed that one. Then which structure is going? That is the pancreas. Okay, so tell me how many parts the pancreas is having? So what about the uncinate process? Uncinate process. There is one thing called uncinate process. What is that? Head এর পরে না, হেডটা যেখানে শুরু হচ্ছে সেখানে একটা হুক লাইক প্রজেকশন আছে, হুক লাইক প্রজেকশন, that is known as uncinate process. So pancreas will start from the uncinate process, then the head, then the neck, then the body, then the tail. Understood? So it is guarded, then it is also guarded by the neck of the pancreas. Write it down. It is also guarded by the neck of pancreas. Okay? So now tell me this left gastric artery, where it will supply? Left gastric artery ta jeta ache seta kothay supply korbe? So you have to say that is the which side? Lesser curvature of the stomach. This part, right? So it will supply over here. So that is nothing but the left gastric artery. So how many branches it is having? Huh? So there are which are the branches of the left gastric artery? Write it down. There are some esophageal branches. So whatever that is supplying the lesser curvature of stomach, it is also supplying some part to the lower part of esophagus. This is known as, write it down, 3 to 4 esophageal branches. Okay, so that is about the left gastric artery. Okay, so next artery we will get, so this is right, this is the smallest artery coming from the celiac trunk. Okay, so next one is the common hepatic artery. Okay, so next branch, common hepatic artery, has got how many branches? So here you write there are 3 to 4 esophageal branches. Okay, so common hepatic artery, how many branch? It is divided into, first branch ta ki bol? Otar porer branch. First branch ki asbe? Hepatic artery proper. So first branch would be coming, that is known as hepatic artery. So why we are saying hepatic artery proper? So we said liver is having two types of circulation. Ekta ki bolechi ami? Systemic circulation, that is given by the hepatic artery, and another one is portal circulation. So how much is the portal circulation, do you know? Kotota by the hepatic artery? Suppose liver has got circulation, right? So how much it is getting from the this portal circulation and how much for this systemic circulation? Write it down. For portal circulation it is 80%. Okay, 80% comes from the portal circulation. Okay, and only 10%, 20% is coming from this hepatic artery. Now this hepatic artery proper is further divided into ki te bhag hoy? Janis? Right and left, and another one is cystic artery. So before it is going reaching to the liver, so it is giving small branch to the gallbladder. ঠিক আছে, তাহলে it is divided into প্রথমে লিখ cystic artery, then second one is right hepatic and the left hepatic. So what about the other branch? আর কি ব্রাঞ্চ আছে? So আরেকটা ব্রাঞ্চ হচ্ছে যেটার নাম হচ্ছে gastroduodenal artery. Okay, gastroduodenal artery. Another artery is gastroduodenal. So gastroduodenal artery. So it is further again dividing, giving one branch to the stomach. Do you know? Right gastric or right gastroepiploic? Konta? Right gastroepiploic. It is also known as right omental. ঠিক আছে, epiploic ও যা omental ও তাই. Okay, so gastroduodenal artery is giving right gastroepiploic. Right gastroepiploic artery. What about the third branch? So sometime what will happen, cystic artery instead coming from the hepatic artery proper, it is a separate branch. Okay, which is directly coming from the common hepatic. Okay, so you could also write there are 3 branches of the common hepatic. বুঝা গেল, একটা হলো hepatic artery proper divided into right and left hepatic artery, then cystic artery, third one is the gastroduodenal artery, and gastroduodenal artery is giving right gastroepiploic artery. Okay, now the main artery you have to remember, that is the splenic artery. So tell me how many branches? What are they? তিনটে ব্রাঞ্চ আছে, কি কি বল? So suppose spleen is situated where? On the most left. Okay, in between we have got stomach and also the pancreas. Okay, and also the spleen. So how many branches it will give? It is giving any branches to the stomach? So immediately after origin it will give branches to the pancreas. Okay, so write it down. First, number one is pancreatic branches. Pancreatic branches. So these pancreatic branch, if it is divided into two, তাই তো গোটা প্যানক্রিয়াসটায় two type of arteries are there. Who are they? One will give the major artery for the pancreas, that is known as arteria pancreatica magna. Okay, so write it down. Number one is arteria pancreatica magna. আরেকটা কি আর্টারি আছে? Arteria pancreatica magna. Another one, it is only supplying to the tail of pancreas, because you know it's very essential for different type of cells. So tail has got its different blood supply. What is it is called? Arteria, tail মানে কি? Cauda pancreatica. ঠিক আছে, arteria cauda pancreatica. So you are giving the name, right? Arteria cauda pancreatica. আর কি আছে? So suppose it is supplying the stomach. Which artery it is giving? Short gastric. So it is supplying twice. It is supplying twice to the stomach. কি করে? একটা হচ্ছে short gastric আর একটা হচ্ছে left gastroepiploid. বুঝতে পারলি? So this another artery is the short gastric. So tell me where the short gastric will give. I will come afterwards. I will come along with the image where the artery will supply. Okay. Short gastric কোথায় supply করে? Very good. Fundus of the stomach. Okay. তাহলে short gastric artery. এবং আমি বলেছি short gastric is a content of which ligament? Peritoneal ligament বলে দিয়েছি এর আগে দিন। short gastric কিন্তু একটা লিগামেন্টের একটা কন্টেন্ট, সেটা কোন লিগামেন্ট? বল। গ্যাস্ট্রোস্প্লিনিক। ওকে, গ্যাস্ট্রোস্প্লিনিক। দিস ইজ দ্য কন্টেন্ট ইজ শর্ট গ্যাস্ট্রিক। আর এখানে কি আছে? লেফট গ্যাস্ট্রোএপিপ্লয়েড। Okay, understood? So this is the branches of the celiac trunk. Okay, now one by one already I have discussed the left gastric artery. The next one is our thing is the common hepatic artery. Okay, so common hepatic artery, if you draw the liver, it would be divided into right and left hepatic artery, and another artery which is giving to the gallbladder, that is known as cystic artery. Okay, so what is our major concern is the third one. Okay, so that is the splenic artery. Okay, so write it down, some feature for the splenic artery. Which are the feature for the splenic artery? So we will tell splenic artery, which are the feature? So this is at first, this is the largest branch coming from the celiac trunk. Number one, this is the largest branch which is coming from the celiac trunk. So write it down, splenic artery. So number one is the largest branch. কে বললো রে smallest? Smallest না, largest. আচ্ছা আচ্ছা ঠিক আছে। Second one is the tortuous artery. Okay, tortuous. Now tell me, tortuous, which are the other tortuous? রিবসে একটুখানি থাকে, হ্যাঁ কারেক্ট। তুই 4 নম্বরটা বললি, তার আগে 3টে আছে বল। একটা তো হয়ে গেল স্প্লিনিক আর্টারি, ওকে, মোস্ট কমন এক্সাম্পল। আর facial artery, because we are having lots of expression, facial expression, mastication, chewing, speaking, everything, talking. So face needs more blood supply, right? So this is the second example, is the facial artery. Who will tell the third one? You told the fourth one. Uterine artery. Okay, so write it down. Actually there are 4 tortuous artery. Okay, number 1 splenic artery, then second one facial artery, third one is the uterine artery, fourth one is the intercostal artery. That is also you have found somewhat tortuous course. Now the question is, already I told you why the splenic artery is tortuous. There are 3 hypotheses, this is not confirmed. Okay, write it down, explain why splenic artery is tortuous. So number 1, কি cause হবে বল? So first one is the due to abdominal distension. Okay, number 1 is the due to abdominal distension. Abdominal distension, number 1. Then second one is, what is the second one? So second one is the spleen has to move during respiration. Second cause. Okay, spleen has to move during respiration. Okay, third one. Who will tell third one? 3 number কি cause বল? So write it down, destruction of RBC. Destruction of RBC. How? What is the normal shape? What is the normal shape of RBC? Biconcave. It is not circular. So if it has to move during the splenic artery, it has got a tortuous course. So incidentally it is got damaged. Okay, so this is the third cause. So write it down. Third one is destruction of RBC. Any other cause? Any other cause? আর কোনো কজ আছে কি? আরেকটা বলেছিলাম তোদের। Spleen is known as reservoir of blood. So during critical condition, it is acting as a blood bank. Okay, it has to pump the maximum amount of blood to the body. Okay, so write it down. Fourth one is as a reservoir of blood. Fourth one is the reservoir of blood. Okay, so these are the causes. Okay, why splenic artery is tortuous. Now one by one artery will come across. Okay, so tell me another 2 artery. Which are the 2 artery? We have got, one is the short gastric and another one is the left gastroepiploid. So about short gastric, you write it down. Short gastric artery. So number 1 is the short gastric artery. Where it will supply? It will supply the fundus of stomach. Okay, and another one is, it is the what ligament I told? Gastrosplenic. Okay, so write it down. So where the gastrosplenic ligament, which curvature you will get, do you know? Gastrosplenic কোন curvature? Okay, greater curvature. So it is the main content of gastrosplenic ligament. Okay, and where it is found? Greater curvature. Okay, it is found on the greater curvature. Understood? So it is found on the greater curvature. Okay, main content ki ache? Short gastric artery. So next artery is the left gastroepiploic artery. Okay, don't come today's class, if don't interrupt between, okay, whomever may be, ঠিক আছে যখন ক্লাস চলবে, okay. So see, this is the short gastric artery. Okay, next one we are having, that is the left gastroepiploic artery. So tell me about left gastroepiploic artery, where it will supply? Anastomos with the right gastroepiploic artery. Okay, so write it down. The next one is the left gastroepiploic artery. Okay, okay, so where it will supply? It will do anastomosis with the right gastroepiploic artery. Okay, and it will found where? To the greater curvature. Okay, so this is about the celiac trunk. Okay, so anything else you have to know? There is another ligament, that is, one is gastrosplenic, another one is splenorenal. Okay, write it down, splenorenal ligament. Splenorenal ligament. Okay, so splenorenal ligament, which are the content? Why I ask? Because one of the structure is the content. Right? Which is the content? Which artery is the content of splenorenal? Lineorenal or splenorenal? Left along with the tail of pancreas. Okay, so write it down. এটাকে আমি বলতে পারি both lineorenal, also another one is splenorenal, whatever you will call. Okay, so what is the content? Number one is left gastroepiploic, okay, and second one is the tail of pancreas. Don't forget the tail of pancreas. Okay, now tell me, what would be the extension? This lineorenal or splenorenal, what would be the extension? কোথা থেকে কোথায়? Obviously spleen to up to the kidney, and which side? That side, left kidney and left adrenal. তার উপরে adrenal, don't forget the adrenal. Okay, so it adhere to the left adrenal, left kidney to the spleen. Okay, and what is the content? Tail of pancreas and left gastroepiploid. A short gastric ta kaar pelam? Gastrosplenic. Okay, so how to palpate the celiac artery? How to palpate the abdominal aorta? Where it is situated? Just above the vertebral column. Already I told you the level from the T12 to the L4. Okay, so from that very minute one you will get this celiac trunk. Okay, it is coming from the T12 and it is guarded front by the stomach and some part of the liver, inferior surface of liver. Both organ you have to remove. Then next artery would be coming to the superior mesenteric artery, right? So superior mesenteric artery would be giving branch to the, also to the this foregut. Okay, so which is that artery? Write it down. Inferior pancreatico-duodenal artery. Inferior pancreatico-duodenal artery. Okay, and another artery of the celiac trunk is superior pancreatico-duodenal artery. Okay, another artery is coming from the, which is the branch? Do you know the branch is coming from where? I told this gastroduodenal artery. One is the right gastroepiploic artery. Another one is the superior pancreaticoduodenal artery. I missed this one. Okay. So this one, another one is the gastroduodenal artery. Another branch is superior pancreaticoduodenal artery. Okay. So now this superior pancreaticoduodenal artery is again divided into anterior and posterior branch. Okay, write it down. Superior pancreaticoduodenal artery is again divided into, তাহলে যদি anterior branch টার কি নাম হবে তাহলে? Superior anterior pancreaticoduodenal artery, superior posterior pancreaticoduodenal artery. বুঝতে পারলি? And now which is the anastomosis between the artery of the foregut and midgut? So এটা একটা question আছে, write it down. Anastomosis between the celiac trunk and superior mesenteric artery. Anastomosis between the celiac trunk and superior mesenteric artery. কি হবে তাহলে? So I told you developmentally both duodenum and pancreas develop together. তাই তো? C shape কি থাকে? Pancreas থাকে, duodenum টা encircle করে থাকে. So these arteries supplying both pancreas as well as the duodenum. So it is having anastomosis with the superior anterior posterior pancreaticoduodenal is coming from celiac trunk and inferior pancreaticoduodenal coming from the superior mesenteric artery. Understood? So write it down. Superior pancreaticoduodenal artery, in bracket you write celiac trunk, okay, and inferior pancreaticoduodenal artery which is coming from the superior mesenteric artery. বোঝা গেল? So this is the anastomosis between the foregut and midgut. ঠিক আছে, আর inferior pancreaticoduodenal artery is giving where? It will give supply to the foregut. এটাও কিন্তু কোশ্চেন আসতে পারে। Okay, inferior pancreaticoduodenal artery is also supplied to the foregut. Okay, so this is all about the celiac trunk. Tomorrow we will come across about the superior mesenteric artery. Okay, today you go through the what are the branches of the abdominal aorta and what are the branches of celiac artery. Celiac trunk is very commonly asked question. Okay, both superior mesenteric artery and celiac trunk.